three
We'll
faculties
improve on the
minimum
gadgets,
for a
what is
discussion.
required. Okay.
And we have nearly 35 faculties who are consented to come here.
Now it's
All of
live.
them are very senior
Live.
people. All of them are potential examiners. So you have to note down the questions. Okay, fine. And for the first session, we don't have any introduction. Dr. Muthu Veeramani is one renowned urologist, not only throughout our country, but internationally renowned urologist. Former president of TAPASU and former president of Madras Urological Society. Sir will be a fantastic examiner if he gets a chance. So he is there for the first session. And along with him, another international personality is with us, Dr. Ananthakrishnan Sivaraman, who brought in robotic surgery into India. So Anant also doesn't need any introduction to both of us. So they are ready for the program. Only thing is, we'll just wait for 2 minutes for the HOD to come and give a formal remarks before we start. The session will be like 45 minutes. It will be like an exact case presentation which you have in your classes. Starting from the history, it will go on to the investigations till your management. At the end of the day, we are not going to give you marks for this, but you will have to assess your own selves and we will also assess you. Around 30 minutes, there will be a call to the faculty saying that 30 minutes is over. So that by 45 minutes, we'll be able to finish one case. In between, if we get opportunities, we'll try to put in certain X-rays or certain images so that we keep you occupied. Okay?
சார் இது காம்ப்ளிகேட்டட் சார். என் ஃபோனில் வாய்ஸ் வர மாட்டேங்குது. நீங்கள் யூடியூப்பில் போய் பாருங்களேன்.
Have the first four candidates been selected? Karthik? Yeah. You can ask them to come to the front row. First four candidates will come to the front row.
Karthik சார் வந்துட்டார்.
Good morning, everyone. I welcome all of you for this program. I welcome Dr. Ananthakrishnan Sivaraman sir. I welcome Dr. Muthu Veeramani sir, and all the postgraduate students. Please make best use of all these faculties.
வந்துட்டு இருக்கு. We need to keep it like this.
Let's Let's get the program going. May I request Professor Muthu Veeramani and Professor Anantha Krishnan to kindly be on stage for the faculty, please. Karthik, if the first 4 candidates have been allotted.
Yes, sir.
Yeah. The session is for 45 minutes. It will be a routine case presentation. Dr. Satish will be presenting. Around 30 minutes for the faculties, we will hit a small bell. So this is 30 minutes reminder so that we close the session at 45 minutes. I request 2 things. Both the faculties as well as the candidates, we have to use the mic because it will be audible for all of us. Session is over to Dr. Anantha Krishnan and Dr. Muthu, sir, please.
This is being recorded. And it's going live.
Hello, you're being recorded and going live.
Okay.
Hello, good morning. Good morning. First and foremost, welcome one and all to Madras Medical. You know, this is all you. Good morning, one and all. So it's a pleasure to be here. Like Dr. Shankar sir said in his welcome video, I think there's a video that was sent on WhatsApp. This is one of the oldest departments in urology in India, I think. And you must all be really fortunate to come and listen to all the faculty that sir has organized. Before I start, there are 2 or 3 things that I'd like to say. Whenever we are in an exam, the idea is there are 3 types of questions that you will get, or the examiner expects 3 things. Number 1 is it's called must know. If you don't know this must know questions are answers you should be
It's not
able to know. It
standing,
will
it's
usually be
dropping down
basics.
like this.
And if you do not know them, then it's a definite not pass kind of situation. Number 2 is called desirables, right? If you know them, it's great, right? If you don't know them, it's more or less all right, I think.
Just check
Number
on
3 is finally called brownie points. That is, if you're going for a prize exam and all those sort of things, that is called brownie points. So 3 types of questions, 3 types of answers. You should never not know these must know questions. You should always be able to give answers to them. So that's number 1. And this sort of mock exam is an amazing concept where they allow your ideas to be critiqued in abstract rather than your ideas to be demolished in reality. So this is the place to make mistakes and make sure you ask us questions, and we'll try and answer to the best of our. I will try and answer to the best of my. Sir is a renowned person that I admire, and we've all been trained in Madras Medical, and it's always a pleasure to come back to our parent institution. I must thank Shivashankar sir for organizing and allowing us to come back. Thank you, sir.
Anantha, I request Shivashankar sir also because he's one of the renowned examiners. Sir, very please, sir.
Shivashankar sir was my teacher as well, so pleasure.
Able to hear me?
Very good morning.
Very good morning. The mock is one of the very good learning point when we face the exam. I hope I remember we were the first of MCA students had our first mock examination in our country. We had it in Madurai Meenakshi Mission, and that was the first time introduced in a country that mock examination organized by Dr. Murali from Madurai Meenakshi Mission. So it's a very good learning. So you will face the examiners 2 times, 3 times, 4 times. Then when you go appear for your final examination, you will be knowing who are all the examiners, their viewpoints, and their fantasies and fallacies. So you have to, somebody is coming from certain, you should be ready with your answer. Like this examiner may like this. Different people have their different approach. So, but I am here to learn from you people because you people are reading daily. So I would like to learn from you. So many of the time I may not know the answer, the question I am asking. So I would like to get the answer from you people. Thank you.
I'm the from SRMC.
Dr. Mayur from the KMC.
Dheeraj from Apollo, sir. I'm Dr. Tarak from KMC.
A 60-year-old man presented with the chief complaints of strain to white for past 2 months and weak stream 2 months. He had no history of hesitancy, intermittency, and no history of frequency, urgency, nocturia, and no history of incontinence. He had no history of hematuria, pyuria, and calcaluria, no fever and vomiting, no loss of weight, loss of appetite, and no history of bone pain. Yes, sir.
We have short time.
Yes, sir.
Discuss more.
Patient is a known hypertensive on tablet amla and atenolol for the past 10 years. He is a non-diabetic, no history of tuberculosis, no COPD, no CAD, and epilepsy. No history of surgeries in the past, no history of trauma, no stone disease, or no history of peripheral instrumentation. He is personal family history. His mixed diet, not a non-smoker and alcoholic, no significant family history. On general examination, patient is conscious. Yes, sir.
A 60-year-old male, sir, with complaints of LUTS in the last 2 months without any significant storage LUTS, sir. He's having voiding LUTS and there is no history of incontinence. No constitutional symptoms. Uh, So right now you have this gentleman that you coming with low urinary tract symptoms. In the exam, you will take the history. So ideally, you should have an IPSS score at the end of this step, right? Because that's important. That's how you're going to grade the severity of the symptoms. So that's quite important. You should ask the presenter what the IPSS score was. This sort of situation you can ask, but in the exam, you're expected to have an IPSS score at the end. It's important.
It includes the symptoms of frequency, urgency, nocturia, urgent continence, and post stream, incomplete emptying, straining to void. We'll grade them into according to the severity and into mild, moderate, and severe symptoms. 0 to 8, 9 to 17, and 18 to 20.
Have you done that? No. No problem. what do you want to discuss? With this history, what you have in mind, and what are the things you want to discuss with your exams?
Sir, the patient is experiencing lower urinary tract symptoms, sir. So, I would, so pertaining,
Time, you have short time, discuss more.
pertaining to his age, there could be a prostate problem, sir. Uh, it could be an infection, sir.
You don't talk like this in the exam, man. Like, it could be a prostate problem, you don't talk, it could be a prostate problem, it could be an infection. You tell me what is in your mind, the differential diagnosis of the thing you have to tell. A 60-year-old gentleman with this symptom, what is your differential diagnosis? Only if you have something in your mind, you go next, no? In physical examination, what you have to see and what you have to, what investigations you have to order. And do you want to discuss? You can discuss.
Sir, the 60-year-old gentleman is having obstructive lower urinary tract symptoms with no storage symptoms. So I'd like to ask more about, as of now, based on this history, my differential diagnosis, considering a 60-year-old and he is not having diabetes or any other comorbidities or any features of urinary tract infection. It could be benign prostatic, a bladder outlet obstruction, sir, probably secondary to a benign prostatic hypertrophy, or it could be a stricture, or third differential diagnosis, I would keep it as a carcinoma prostate. And rare things are primary bladder neck obstruction, which is quite rare at this age, and he's not having hypertension and other things.
What is the relationship between hypertension and bladder outlet obstruction? You mentioned that, no?
Yes, sir. Sir, primary bladder neck obstruction is common in middle-aged men, sir, usually with a stressful lifestyle and who also have associated hypertension. Sir.
Hypertension is a generalized disease.
Yes, sir.
You mentioned specifically that hypertension, that this fellow doesn't have a hypertension, so
Yes,
you will not consider as a bladder neck hypertension.
Yes, sir.
Is there any correlation between hypertension and bladder outlet obstruction?
I'm not sure. It happens in middle-aged hypertensive.
So
sir.
you only committed, that is
Yes,
what.
sir.
That is not, you don't settle it in examination. Okay.
Is that a sympathetic overdrive?
Yes, sir, sympathetic.
That is what is asking. Huh? So, what is the treatment for that? You're giving alpha blockers. What are you doing in effect?
In primary bladder.
Sympathetic overdrive. So, what are the treatment modalities we suggest to the patient is
Alpha blockers.
reduce their
Stress level and
also important.
Okay, with this differential diagnosis in your mind, what do you want to do? What do you proceed?
Sir, I would like to ask about this, if there was any history of urethral discharge or those things also.
General examination.
Yes, wait. What do you want to see in
Sir, general examination, general examination about his consciousness, other things, sir, and the performance status, and also if he has any.
Tell something, something very,
Okay.
yeah. You had BPH, you had CFSG, you had other things in mind.
Okay.
Put in mind and then you examine.
In general examination, specifically, I look for if he is having any pedal edema, sir, and or any other early signs of chronic kidney disease, secondary to the obstruction, sir. And then I will do a focused urological examination, sir, wherein I will do a examination of the abdomen, wherein I will see if bladder is palpable, if there is any loin tenderness, if there are any previous scars, and how is the hernial orifice. And genitalia examination, I'll see, sir. I'll see if there is any phimosis or how does the meatus look. I mean, if the meatus is open, and urethra I'll palpate to look if there is any spongiofibrosis or anything, sir. And I'll do a scrotal examination, testicular size, if there is any epididymal tenderness. And I'll do a digital rectal examination, sir, wherein I'll see for the size of the prostate, if there are any palpable nodules, and how is the anal tone, if there is any fecal loading, these things also.
On abdominal examination, all quadrants move equally with respiration, no scar sinus, and umbilicus centrally placed. On palpating the abdomen, no palpable mass, normal resonant abdomen, bowel zones present. External genitalia, penis, prepuce, no phimosis, uncircumcised, meatus glands normal, shaft normal, testicles, scrotum normal. Rectal examination, tone normal, grade 2 hard, non-tender, non-nodular prostate, mucosa of prostate is free.
This one here, for the purpose of examination, now you put grade 2. Grade 2. So what do you mean? How do you grade the person? Tell me something, how do you grade the person? Something reasonable.
Sir, clinically, how much it encroaches the rectal lumen, sir? One finger or two fingers or three fingers or four
How do
fingers?
you do? How do you do? You do DRE, how do you assess whether you want to do it? It's subjective.
Yes, sir.
How do you do?
Sir, left lateral position, sir. Lateral position I will do after consulting the patient. Okay. Plus base whether my finger is able to get over the upper border of the prostate, sir. Completely gets over it is grade. With difficulty is grade 2. Sir, that's why it is objective, sir. It depends on, it is not subjective, sir. So it is not reliable, sir. It may vary depending on the examiner and the examiner's context, sir.
When you pass in the examination, you must be able to tell something reasonable. Okay, with the examiner. Okay, right. Now, when now the statement grade 2 hard non-tender. Anything, any importance you want to give to this hard?
Sir, if there is any nodules or anything, sir.
Yes, what is hard? What do you want to ask me further? But next is non-nodular prostate. Too hard.
Yes, sir.
The next step is non-nodular prostate.
Okay.
So what do you want to ask me next?
There is any.
What do you? अरे बोलो यार.
Sir, by hardness we can see the sir one side or bilateral sir on the prostate sir. So we can give the grades.
You have to quantify it, whether you have the staging in prostate malignancy. So what do they say? Half of one lobe, more than half of one lobe and both lobes. That should be there when you're writing in an exam, right? All the other points are very important. Non-nodular, mucosa free of the prostate. Again, that tells you whether it's a case that is potential for amenable for surgery or not, right? So all that is very, very important, has to be. And again, grade 1, grade 2, grade 3 is so subjective. My suggestion is put a number to it. When you feel it, you say 30 gram prostate, 40 gram prostate, 50 gram prostate, whatever, right? Over a period of time, you'll be able to corroborate with the ultrasound.
All are
and
able
then-
to hear? Back, huh?
Over a period of time, you'll be able to corroborate with ultrasound. Throughout your life, it is important. Otherwise, this grade 1, grade 2 becomes a big gray area.
Okay, and the last one.
So what is the non-nodular prostate? What is the causes of nodular prostate?
Maybe it is because of CF prostate, BPS, granuloma, impact of maybe sometime old uses.
Now, last point in this will go next. Some examiners, some old timers will not like to grade a prostate when it is hard. Okay, please keep it in mind. In hard prostate, they won't grade it.
Systemic examination. Audio specific normal, RS, CNS, microtherapy examination normal.
Okay. Do you want ultrasound? Wait. Yes. What do you want next? After your systemic examination and the confirmation, what do you want next?
Requires USG kidney ureteral data sir. With prostate, with PVR sir.
We want only kidney, ureter, bladder. We don't want to examine the whole abdomen.
First of all, sir, to extend my examination, I require first KV with bladder, KV with prostate and PVR sir. Then after this, require
This radiology sending back to you with a report saying that there is a nodule in the liver.
sir, then we can suspect.
So what makes you to stop ordering for a ultrasound whole abdomen rather than KVB alone?
Clinical practice best or ultrasound abdomen.
If you specifically say KUB, you are missing the liver, then the radiologist may not report it because you are asked only about the kidney, ureter, bladder.
Yeah, this is a very important point. In your practice, always order for the ultrasound of the abdomen. See, many radiologists, when you ask ultrasound of KEB, they just restrict to KEB. But that is not sufficient. You have done ultrasound abdomen,
So that you know about other things also. Okay.
And the cost wise also it will be saving the patient.
Yes, sir.
May not be much difference between you ask for a whole abdomen and KOP. Yes, sir.
What is the finding? This is ultrasound.
So ultrasound, which is a, of course, the right side kidney, it's a look like, sir, that corticomedullary differentiation.
Normal or not normal?
Normal, sir. Okay, one side kidney.
Prostate is normal.
These are normal. Prostate, good previous life. Yes. Measurement is not given in this. Not able to see.
No, sir, look like any hypoechoic nodular.
Obviously it is enlarged.
Yes, enlarged.
Enlarged. Maybe the one you want to make.
Okay. Intravesical extension is there, sir. Here, liquid one and let us see.
Anything striking? What come back? Anything striking on your X-ray KV? What will you look for? So one of your clinical diagnosis CA prostate. When you are suspecting CA prostate, what will you look in a plain X-ray KUB?
Sir, for looking, sir, any metastasis in the vertebra.
How will it looks like in a?
Sorry, there is a osteoblastic, sir. So it should be.
Is there any osteoblastic or osteosclerotic lesion in this X-ray KUB? That's what my question. No. What is that hyperdense whitish area on the left sacroiliac joint? Will it considered as a normal or something abnormal?
Or is it artifact?
Or that is another hyperdense area in the
It is
right inferior sacroiliac joint.
it looks like, sir, artifact, sir.
How do you differentiate between osteosclerotic and artifact?
Sir, it is mostly starting in the prostatitis from the vertebra, sir. In the lumbar area, sir, thoracolumbar area. Is most of the here the thoracolumbar area, sir. One sclerotic reasons look like it's there, but there is a more on the pelvic LI, sir, on the left side. Wings.
Ultrasound and your X-ray KUB, do you have or do you draw any inference?
Sir, by that mostly it look like a benign prostatic hyperplasia, sir, enlarged prostate by USG and the patient symptoms, sir.
Okay, supposing the secondaries in the bone are osteosclerotic. That's what you told, no? Supposing you get osteolytic lesions. Can you get osteolytic lesions in CA prostate?
Sir, can be possible in the CA prostate in the variety of the prostate carcinoma. Which is,
Supposing you have osteolytic lesions in CA prostate, what is the prognosis?
the prognosis is poor, sir, on that in osteolytic lesion, sir. It is maybe a squamous cell carcinoma.
These are like some examinations.
You can get
Undifferentiated.
osteolytic even in adenocarcinoma. The percentage is much lower. Right?
What percentage will get osteolytic lesion? What percentage will get osteosclerotic lesion in an adenocarcinoma prostate?
Sir, nearly 5 to 10% we are getting, sir, osteolytic lesion.
That's right.
Your answer must be that yes, you can get in a poorly differentiated adenocarcinoma, in neuroendocrine tumors, in squamous cell carcinomas. All these conditions you can get a osteolytic secondaries in case of the prostatic malignancy. Okay. What specific investigations do you want?
Sir, I would like to ask about serum PSA, sir.
I would like to ask serum PSA.
Next, how will you proceed? Now, you've got a serum PSA. Now, this 60-year-old man obstructive blood serum PSA is high. So, what is the next step? Do you want to treat that gentleman with some antibiotics and then repeat PSA, or you want to proceed based on this?
Yes, we want, it is more than 10 nanograms per ml, so it's relatively high, so I want to proceed with the trust scan plus or minus biopsy.
Will you ask only the total PSA or a fully PSA? Or both?
It's not in the gray zone, so total PSA will be fine. Sir. If it is in the gray zone, then I'll ask for free PSA.
And this question is asked so many times in the exams, whether you want to repeat the PSA. If there is no clinical corroboration or it says where you think in terms of prostatitis or something, you don't need to repeat it. The prostate is hard, the PSA is high, 60-year-old gentleman, no urinary irritation symptoms, so you can go ahead with
Culture is done.
evaluate. Culture is correct, right? So go ahead. What do you want next?
Trust scan plus or minus biopsy.
Why trust scan? What is it? What do you expect to see in trust scan?
We can see any hypoechoic lesions,
No,
which
so
can be
what is the
targeted in the
significance of a hypoechoic lesion? So in other words, how many cancers present in lesions?
in CA prostate around 60% present.
Yeah, what happened to the other 40? What is the basis of doing a trust scan? So somebody else wants to talk about this?
Any comments you want to make? Even any time that when you want to make some comment?
At present, doing a trust scan after a high PSA is not going to add anything. That era, right? Currently, as per guidelines, you have to
MPMRI, sir, we have to
do an MPMRI. There is nothing that the trust scan is going to add over and above an MPMRI. Maybe when you're doing the biopsy, you need it, but for diagnosis, that era is gone. No more trust scan. Don't say trust scan is examining. Get it to trust. Last 5 years, things have moved to MPMRI, right? So what we order, what is it?
Sir, it is a multi-parametric MRI, sir. We have to say about the location and the localization of.
What are the sequences you need in an MPMRI?
Sir, T2 weighted ML, sir. ADC and DEC, sir.
So
What is ADC? What is DEC?
Sir, dynamic effusion coefficient.
Don't use activation examination.
Sir, T2 weighted image, sir. And second is
What is ADC?
apparent diffraction coefficient, sir. And dynamic contrast enhancement, sir.
DWA or DC?
Sir, both, sir. First, DWA, diffusion weighting image, sir. It will show the
diffusion weighted image. Weighting image.
weight. It will show, sir, that the Brownian movement of the water, sir, inside the cell.
That is not very clear. This is DWA image, then ADC, and DWA or DC?
Sir, DC,
Or
sir.
both?
Sir, DC, sir.
No. So,
Dynamic contrast image.
so first thing is most of your diagnosis will come in biparametric MRI. Like sir is saying, it is T2 weighted images, diffusion weighted images, and ADC. And only when you have a Pirates 3 entity where you're not able to make sure whether it is malignancy or not, then you can go in for a contrast image. So things are moving away from adding.
I will ask her to repeat this. In the multi-parametric MRI, this is the sequence. Okay.
So you main thing is needed is biparametric MRI. Most of the cancers will be detected in this sequences. T2 weighted images, diffusion weighted images, and ADC. When you have a doubt in a Pirates 3 entity, then you can go in for a dynamic contrast enhancement, and that will allow you to differentiate whether it's Pirates 3 or Pirates 4, right? So, but why it has come to this? Because every time you cannot add contrast, every time you cannot increase the time of the MRI. So most of your answers will be gotten biparametric. And some of the time you need multi-parametric MRI, right? This is the standard. You cannot, no reason to go in for trust, right? Unless you're suspecting there is an abscess and you want to rule it out in the outpatient setting, then there is no reason to go in for trust, right?
MPMRI.
What are the situations where, go to previous slide, this also will be asked in your examination. What are situations where you can get an elevated PSA apart from malignancy?
So it could be a urinary tract infection, prostatitis, or a recent instrumentation,
Once you told prostatitis, next is
uh,
prostatic abscess.
abscess,
Then
recent catheterization or instrumentation, sir.
in acute retention of urine itself.
Acute retention of
Yes, acute. So please be careful. When you do a PSA on the patient acute retention of urine, when most commonly you will get patients who come with the PSA report, which has been done when he had acute retention or immediately after catheterization. So you will have to be doubly sure that it is the true value or not the false value. Okay, in your practice also. Also when discussing also you will see that.
Right, next, what you want, you have the MRI, result impediment is important to read this. Right, okay, if they show you an MRI and ask you to read it, you should be able to read it. So at least the basic points you should know, what T2 weight is, what it looks like next. 5 points, just remember, read up a few MRIs, and in the exam, if you show you an MRI, you're not able to read, it's not great. Right.
Moderate prostatomegaly in the peripheral zone, moderate homogeneous T2 hypointensity with mild to moderate restricted diffusion and early heterogeneous dynamic contrast enhancement in posterior peripheral zone segment of right lobe and posteromedial peripheral zone segment of left lobe, suggestive of PIRADS 4.
What is PIRADS?
Prostate imaging, reporting and data.
Correct.
Prostate imaging, reporting and data systems.
You have to know this. You are saying PIRADS every time you don't know this. So what is the significance of PIRADS 1, 2, 3, 4, and 5? What percentage of cancers you will get in each PIRADS score?
Don't answer this question.
Other than PIRAD, is there any other scoring system?
And currently, what PIRADS version we are using now? 2.0. Yeah. Tell me, what is the significance? PIRADS 1 na evlo, 5 na evlo? What? I'm sorry.
So the probability of malignancy is more than 85 to 90% in PIRADS 5, sir. Almost equal to 100%.
No, not 100%. Never 100%. That's wrong.
For a PIRADS 4 score, it is more than 35%, sir.
No, wrong. What is change? Somebody else?
Sir, PIRADS 5 is more than 85%, sir. PIRADS 4 is more than 70%, sir. PIRADS 3,
Always you have to give a value, it's a range.
okay, sir.
And that taken over value should be a range.
PIRADS 5 is roughly 80 to 90%, sir. PIRADS 4 is 65 to 80%. PIRADS 3 is comes in the gray zone, sir. 50 to 65%.
Wrong. Again, so PIRADS 1 is around 1 to 5%, 2 is around 8 to 10%. And when you go to 3, you have to substratify it based on the
PSA density, sir.
PSA density. PSA density is less than
0.15.
0.15, then what is the percentage? It is 13%. The PSA 13 to 15%. If the PSA density is above, it is 29 to 32%, right? And then 4 and 5 much higher. So if you say PIRADS 3 here, will you biopsy will be a question. There you have to substratify based on
PSA density.
how do you get the PSA density?
Sir, total PSA divided by the prostate volume, sir.
Who gives you that density? The MRI report should have that density in it, right?
All of you got this point regarding the substratum of PIRADS. Okay, it's a very important point. Okay.
Any other than PIRAD, any other system available? Do you know? Ask your radiology colleagues. Any other system other than PIRAD?
Anyone wants to answer? Apart from PIRADS, any other scoring system?
There is a system called Likert.
Okay, give the answer. Like
Likert score.
Likert score.
No, it is a Likert score. No? So it can be a very good radiologist can give a good score compared to PIRAD.
Next.
In transitional zone, there is a T2 hypointense nodule with obscure margins and mild restricted diffusion in transition zone of left apex, suggestive of PIRADS 3.
Okay. So what do you want to do with this? There's 2 lesions. One is PIRADS 4, PIRADS 3. How will you proceed now?
Sir, I'd like to see the other parameters. If there is any imaging features of capsular breach or any nodal enlargement that also will ask for an MRI report, sir.
Go ahead.
Nodal enlargements.
Nothing. Okay. So what is the, like, from an MRI, what have you got from? It is a localized.
Localized.
So what is the MRI telling you? It is local staging MRI is telling us, right? So, and there are two lesions, Pirates 3 and Pirates 4. How will you proceed?
Sir, I'd like to go for press or transperineal biopsy.
That's a, 15 minutes. 15 minutes. Right. So next.
Why do you want a transperineal biopsy? Why not transrectal biopsy?
Sir, transperineal is supposed to have less chances of infection, sir. And also it can sample the lesions which are more in the anterior wall, sir, which can be missed on transrectal biopsy, sir.
You have assisted a lot of transperineal biopsies. You have no?
I've seen.
Yes, you have seen. Okay. How many courses do you take? Either transperineal or transrectal. How many courses do you take?
Sir,
Minimum.
first we will take the suspicious nodules, sir, 2 or 3 from the targeted biopsy, sir. Then we take a total of 12 courses, sir, apart from the targets.
Okay. Okay. So when you do a transperineal biopsy, how many incisions?
Sir, we can do it in a single incision if we have the coaxial needle, sir. If not, for each and everything, we need to make multiple punctures.
All of you got the point? What he is telling? Okay.
So the important thing is, like, sir is asking, transperineal biopsy, there is only one incision on either side of the rectum. For the left, there is one, right? So put a coaxial needle and you can take multiple cores. Standard protocol for doing a biopsy, any biopsy, interest biopsy or transperineal, is 3 cores for each of the lesions that you see. If you have 2 lesions, so 3 plus 3, 6 cores should be there. Apart from that, it's a 12-core standard biopsy that should target areas of the prostate, right? This is systematic biopsy plus targeted biopsy. So minimum will be 15 because nowadays we don't take biopsies without targets most of the time. So 12 plus 3, one target 3. If it's 12 plus 3 plus 3, it is 18 biopsies you will take, right? So in this case, you should have had 18 biopsies. So what else do you expect from a biopsy? What do you need from a biopsy here?
Sir, Gleason scores a number of cores positive, and there is any adverse factors like perineural invasion.
What does perineural invasion mean? Has he taken biopsies outside the prostate to show the neurovascular pattern?
No, sir.
What does it mean? Where do the nerves come from? Perineural means invasion of nerves, yes? Where do the nerves come from? Inside the prostate. So that is the way in which the tumor comes out of the prostate. Perineural spread is one of the most commonest spreads of prostate malignancy. So what do you expect from a biopsy is, number one, you need to know number of cores, how many cores are positive, what percentage of malignancy in each core should be mentioned, is there a cribriform pattern present, is there a ductal component present. What does a ductal component indicate? Does ductal component have a Gleason score? It's a ductal carcinoma prostate. Should it have Gleason score? No, sir. What should it have? So it has to be mentioned what is the predominant score should be there, but you can
solve poor prognostic
adverse predictive factors. All that should be mentioned when you give a report for the presenter. In the exam, you should ask all these components. Don't go too deep and trouble the examiner.
Don't get into trouble.
Don't get into trouble. Okay. Right.
What is the need for scroll, gray, group? So many things.
Sir, with this data, we risk stratify the patients. Sir.
So what is the commonest risk stratification that you use?
Sir, we use EAU or NCCN or DMECO, sir.
Is the available data enough to risk stratify?
Yes, sir. With this data, we can risk stratify according to NCCN, sir.
That's important. So it is a clinical risk stratification that we always do. You don't go in by PSMA PET scan, the DMECO risk stratification. This is important, right? Next. next one.
You want to answer this question? It was DMECO risk stratification. So what is the risk stratification? Quick, fast.
It includes serum PSA, Gleason score, and T stage of the
Okay, how do you risk stratify it?
serum PSA less than 10,
No, this will be the risk stratification.
low risk intermediate risk and high risk.
Anything, any sub-classification to this?
In NCCN, we have very low, favorable intermediate, unfavorable intermediate,
Okay,
and
in
high.
NCC. Okay.
PSMA PET scan, why not, the commonest PET scan we're using FDG PET scan, why not FDG PET scan?
Because the prostate cancer cells are not that much metabolically active, so they don't use glucose much to get detected by the FDG PET, and PSMA is one of the biomarker expressed by the cancer cells, so it will detect more of the cancer activity, PSMA PET.
All cells use glucose. What do you mean? I don't understand this comparison.
So more of indolent cancer, the cells are more.
So there is a name for it. It's called, usually it is by citric acid cycle, but for the cancer cells use aerobic glycolysis. But prostate cancer cells do not do that. That effect is called aerobic glycolysis used by cancer cells. It's called Warburg effect. But these prostate cancer cells, if they are intermediate and low grade cells, do not use this Warburg phenomenon, and hence they don't take up the glucose that comes in FDG PET scan. PSMA, what is it? What is PSMA? So why is it you don't have PSMA in any other prostate cells, or is it only in prostate cancer cells? So he's also talked about biopsy. Suppose you want to ask immunohistochemistry in biopsy, right? Which situations you will ask for immunohistochemistry, and that small things you need to know, right? What will you look for in immunohistochemistry? There is something called AM, AMCAR, race base. What is it? So just go read up about it. You need P63, whether it is present or not. Then AMCAR, whether it's present or not. All that is important. And what is PSMA? Where is it seen? Is it a transmembrane protein? What is it exactly? Right? And that's this sort of questions they will ask. Right? Second, I'm just going to quickly skip and go into that. There is something called FAP. That sort of PET scan is also coming in future, right? So that is also important to know, right? What is it that you're looking for in a PET scan? Standardized uptake value. So it is not only what you see in the prostate. Suppose you have to quantify the lymph nodes and all that. There should be a reasonable standard uptake value to give answers in PET scan, right? Yes. Okay. Let's go. Right. Okay. It's a localized prostate malignancy, yes? Right? Now, how will you proceed? Let's finish with this. The T2C, N0, M0.
Can you sum up, Tarak? Just.
Sir, he's a 60-year-old male with a TC and N0 disease, sir. So his life expectancy is definitely more than 10 years, sir, because there are no other comorbidities that we can elicit with WHO tables. So I will advise him to go for a radical procedure in a curative intent.
I don't want radical prostatectomy.
Sir, the other option are primary radiotherapy, sir.
I think this is okay, no?
No. See, you have to qualify your answer very. So this case, when you talk about this case, is 60-year-old man with high risk localized prostate malignancy. Why high risk? Because Jesus population.
Yes.
These are the following options that I will give him. Otherwise, you are allowing sir to ask questions like this one. So your answer should
based on shared decision making, I will advise.
Shared decision making.
That is very, very important.
Yes, sir. I will advise them radical prostatectomy, primary radiotherapy, and I will not advise active surveillance in this case. So among these two,
very good. That That is what is expected. So shared decision making, the following options are available: radical prostatectomy and primary radiotherapy. What are the potential complications that somebody can get in radical prostatectomy?
Sir, positive tumor margins after the surgery, incontinence after surgery, erectile dysfunction.
Percentage you'll tell your patient that if I'm doing a radical prostatectomy, this much of percentage I may likely crack a positive margin. You have to quantify that, otherwise the patient, if you say the 90% margin, they may not come to it.
Yes, sir.
What is the standard, what is the evidence says that?
Less than 5 to 10% chance will be there.
So you have to quantify. If it's a T disease, it has to be up to, it can be up to 10%.
Yes.
If it is T3 disease,
It will
it
be
is
more.
much more, 20 to 30%, you will get positive margins. Incontinence rates, they will ask you.
Yes.
Sexual dysfunction rates. Throughout this entire discussion, we've not talked about sexual function of the patient at all. So whenever you are counseling a patient for prostatectomy, you should have a, like, what is that score that you use for sexual function?
IIEF scores.
IIEF or SHIM score can be used as well, right?
Yes.
What is the full form of SHIM? Allah later on. You have to know how these things will come. Right? Next. So if the patient goes in for what about incontinence rate?
Incontinence rate, sir, 90% of patients will gain continence by 6 months after, sir. Rates after radical prostatectomy, they up to 40 to 50% gain after 1 to 2 months of surgery. With the rehabilitation, the rates are up to 90% after 6 months.
So other thing is, don't get into this robotic prostatectomy or laparoscopic prostatectomy. That discussion better left unspoken in the exams.
No.
All we need to know is which modality, either surgery or radiation. That is all. This is all is expected, not beyond that. Once you talk about if your unit is doing, for instance, Apollo is doing so many of those cases, if you start talking about that, then you'll get into trouble, right? You don't need that. If they ask you, potentially you can talk, but otherwise don't say, I'm going to do robotic and get into trouble. That's not right.
Trifecta, cancer, making the patient cancer free, making it continent, and
Same thing, which
And,
you discussed now, the same thing. it is
negative
putting a
margins,
different way.
and no ED after surgery.
And what is pentafactor? No.
Take the mic, take the mic.
So
Pentafect is less complication and
positive margins, right? So biochemical recurrence, continence, sexual function, trifecta. Positive margins and complications make it pentafactor.
Now you have done a good job, you have done a radical prostatectomy, with whatever methods. Now how do you follow this patient?
So, look for the pathology reports when it comes. I'll see if there is any upgrading or downgrading of the lesions. If there are any margins negative, and I'll also look at the rodal status and if there is any adverse pathological factors.
So note should we do in this case, and what is the extent of node dissection you should have done?
As of this case, definitely we need to do because it's a high risk prostate cancer. Sir.
What will you do?
Sir, extended pelvic lymph node dissection.
So that's important to understand. So low risk prostate cancer, no node dissection. Low risk intermediate cancer, no node dissection. But high risk intermediate and high risk cancers should have extended pelvic lymph node dissection. There is a different matter altogether whether this is curative intent or just staging node dissection. Currently, there is no evidence to show that it is curative node dissection. Only staging value is ascribed to node dissection. But ideally, don't get into it. You will do extended pelvic lymph node dissection in high risk prostate cancer. What are the boundaries of node dissection?
Proximally to the iliac bifurcation, sir, and laterally till the node, and medially all the until the operator nodes.
So what is the standard lymph node dissection?
Sir, proximally is the iliac bifurcation, sir. Common external internal iliac bifurcation, sir. And laterally is the genitofemoral nerve. Caudally is the lymph node of Cloquet, and medially the operator and the deep pockets of operator.
This is extended lymph node dissection. That's
Yes.
what you are trying to say.
Yes, sir. Yes, sir.
Then what is the standard lymph node dissection?
So all bifurcation of the common area.
Yes.
What is the standard?
One step, we will not go more proximally, sir. Other boundaries will be the same.
Where does the ureter crosses? Then question.
At the bifurcation, sir.
Then-
Right bifurcations.
Is also same thing. You are saying extended, you are saying standard.
You have to go a bit more proximity, get up to the common iliac bifurcation. And then sometimes they also have to add the presacral nodes, right? But when you're doing nerve dissection and you do presacral node dissection, you will spoil the nerve system. So again, but also it goes to prove that you don't do much nerve dissection when you're talking about this prostate cancer. But if the question is asked whether nodes are intent or stage in the diagnostic intent, currently there is no evidence, major evidence to prove that, right? So when the biopsy report comes, if it shows that it is a T3A disease, there is microscopic extension. Is there
Examiners may ask you doing robotic surgeries. Is there any role for neo
recurrence free do RT and continue it for 3 years? Why not the same thing for surgery as well? So
Because it's already also T3.
So biopsy report has come, so margins are negative. Will you subject him for radiation?
Sir,
Nodes are negative.
I will see the final Gleason also, sir, in that case. The final biopsy, whether based on the histopathology, I'll stratify him.
So node negative, margin negative, high risk prostate malignancy, T3A disease, or even margins positive, minimal margin positivity. All of them don't come under immediate adjuvant treatment. That concept is slowly going out of vogue. Nowadays, it is only early salvage treatment for prostate malignancy. PSA, you see the PSA and then you follow up the patient. So because now we have highly super treatment, if not early salvage is the standard of care at present. Now, what is the paper that is suggested? Please read it.
and early salvage therapy, and when you
I will start with since on ADT, sir, but I'll definitely.
I don't want any radiation, I don't want any surgery.
HIFO,
We can give, sir, for at a whole gland ablation, we can use.
like what is it?
Sir, for that we can use, sir, radio frequency ablation, cryosurgery, or sir, HIFO, sir.
Cryosurgery, HIFO is used. Nowadays, there's something called electroporation that has come. All of that you have to know, but we have not seen it, right?
Should know that, all these things.
when you get a case, apart from this discussion, you have discussion into brachytherapy, you have discussion to primary radiotherapy, you have discussion what is native PSA, what is the biochemical recurrence, how we manage the biochemical recurrence. All these things you must know when you get the case like this.
And what is watchful waiting, what is active surveillance?
What is the half-life of PSA, they will ask. Why? So why are you waiting 45 days for the PSA to go out of your system? Right? You have to wait 42 days for the PSA to 2 to 3 days, but for the full PSA to go out of your system, it is 42 days. Right? So otherwise, the radiation, like sir is saying, asking nowadays, they're talking about proton. What is the benefit of proton? Right? Yeah, that you have to talk about the Bragg peak. What is the Bragg peak?
So the radiation will be focused, there will not be any lateral spread of the radiation. sir.
Not lateral spread.
It will get focused only on the prostate, so it will not go beyond the area of.
So most of the energy of the radiation is given at the focus point. When the radiation exits the system, it doesn't carry enough energy for it to damage the surrounding parts of the body. So that is the benefit they are talking about proton. But has it made a real difference in OCR or overall survival for the patient?
No, sir.
I don't think not yet proven
Not
to
about-
make a difference in. Srivatsan, has it made a difference?
According to the exam purposes, no, sir. It's
Ah.
similar to radiation. Only the side effect profile is slightly.
Yeah, slightly better side effect profile, but the survival rate for the patients are similar to external beam radiation. Right?
Read about the image guided.
What discussion has gone now is only basically 10 to 20% of what you will get in an exam. So, but go back and read about more about this thing. This is a typical exam case. Okay. Thank you, Dr. Anand, and thank you, Dr. Mukesh.
Dr. Rajaram is here, he was our examiner.
I'll ask two questions. I'll ask. No questions, sir. Doubt.
Now I'm feeling like I'm sitting in the exam.
I'll ask doubt. You doubt.
Thank you very much, Dr. Professor Muthu sir, Dr. Anantha Krishnan, and our beloved Professor Shivashankar sir. That was a wonderful session to start the program with. And let's proceed for the next session. May I request Professor L.G. Rajamanikam, Senior Examiner and former Professor of Royapeta Medical College, Professor N. Muthulata, once again a Senior Examiner and former Professor of Madras Medical College, Professor Rajaraman, former Professor of Stanley Medical College, to kindly be on stage, please. I will request Professor Muthu sir also to kindly join on the stage for the next presentation. Hello. Hello. For the benefit of the faculties, there will be a 30-minute bill, and there is a 40-minute bill. The entire section is 45 minutes. Check.
This is a case of 28 years old male who had a road traffic accident 8 months back and sustained pelvic fracture. Then he developed inability to avoid blooded meatus, clinically palpable bladder. And there was a history of inability to pass via naturalis, following which a suprapubic catheterization was done and pelvic fracture was managed conservatively. Now he is on regular suprapubic catheter change. There is no history of abdominal pain, no history of fever, chills, vomit, of appetite, no history of constipation, no history of urethral discharge. Past history is not a diabetic, hypertensive, epilepsy, bronchial asthma patient. No history of previous major surgeries. No history of personal history. No history of smoking or alcohol. No take mixed diet. On general examination, the patient is conscious, oriented, afebrile. Pulse is rate is 90 per minute. Blood pressure 110/70 per mm of mercury. No pallor, ictus, cyanosis, clubbing, generalized lymphadenopathy, fatal edema. On an abdomen period.
Suppose patient comes to you, what you return? Patient more than injuries.
Check.
Bladder distended.
Check.
So first I will give a complete examination. So first I will give dental trial of first one, trying periurethral catheterization. Sir. So if it is not.
One examine the patient completely. Will you do a hearing?
Yeah, first I will do
all that. Exam, patient comes to you in a trauma. What will we examine the bladder. Of course, no other injuries are there. Abdomen soft. Abdomen is soft. No other injury, no other head injury. All injuries ruled out.
I see the general examination. So I see the blood at the meatus is there.
All the time.
And I see
You
the
should do your most important visual examination.
DRE I check. See the tone of the, then I see
What do
the
you
high
see?
reading,
What will you see?
sphincter tone and the.
Why do you want to see sphincter tone here? Don't get trapped by just sphincter. Why should you see sphincter injury? It's necessary to see sphincter injury. Tell me, why? Why not? Why avoid? Do you see sphincter injury in all traumas get sphincter? In what way is sphincter be injured in a pelvic fracture? Oh, forget it. You see only parental examination. See the prostate.
Then I'll examine the prostate and high reading prostate is there. And apart from the perineal hematoma is there, I'll just examine.
All that is next.
Then then I want to, in emergency, this patient has got a palpable bladder, sir. So it's connected with the retention. So first give one general trial of perineal catheterization.
Before doing a trial, will you catheterize a patient in a fracture pelvic rupture urethra? Or you like to do some investigation before that?
Investigation. First, I want to
Under
bedside.
what do you do?
Then I will retrograde urethogram, sir.
It's called what? What urethogram?
It's a dynamic.
Under fluoroscopy, dynamic, incremental urethogram. Why should do incremental?
So since it is already fracture, there might be a urethral injury leading to the leak of the contrast. So by gravity, we leave the contrast to go so that it will not further.
More than you make partial injury into complete
injury.
You diagnose it. There are various types. I'm not going to go into it. Now, how are we going to proceed?
Just to complete my examination, I just get in bedside
I'm
ultrasound.
not going to
Ultrasound. SPC or
Go ahead with your uretrogram, dynamic uretrogram. So usually you go for all the investigations according to what is available in your hospital. So usually you have a gentle, one time you can have a, they ask you how will you do a uretrogram. So this patient, any other history you ask?
That's very important.
That's very important.
Young man, you have to ask.
Also, I want to ask regarding any emergency with any pelvic fracture, any associated any orthopedic intervention was done that time.
So, at the time of injury, will you ask sexual? He's lying in a trauma, yeah. He's lying in
acute.
Never ask. You do and not. Later on, you can do. When you do one, then you do uretrogram, and there is continuity of the urethra. You can try to pass a catheter. Suppose there is no continuity, the various classifications are there.
Any other way you can find out that it's sexually active? Is it emergency?
Is it?
Married and children of the.
Okay, then you want to divert the urine. What do you do? Do it local, go in bedside, or go in the theater and do it.
So, in this case, I think most of will do
So
is
any
emergency. In
Do
the
you want the local and anesthesia or in theater or bedside?
preferably under anesthesia, sir.
Yes. What do you do first? Do open SPC or trocar SPC?
Trocar especially.
When will you do open?
If associated pelvic fracture extending and any previous history of abdominal injury, surgery, so then scar is there.
Usually, then you go for a open. Usually you go for a trocar on the side to bedside. It's associated with
Other abdominal injuries and
surgeon goes for a
open surgeries then.
At times because of the contusion in the wall, So you may not be in a position to know whether the bladder is palpable properly or not. So it can be ecchymotic, all those things will be there. Some abrasions. In that case, either you do it with the ultrasound guide or you can do open cells.
Bladder is palpable. No bladder. Put a needle. Clear urine. Do a trocar aspiration. Suppose a blood stained urine. What does it signify?
Associated
No,
bladder.
that is gone normal. Everything is normal. Put it as kind of normal. Can there be a bladder injury? Pubic bone pinning into the bladder. Then what you do is do a open SPC. Always put in a needle. Blood stained urine. Then you have to open SPC. That, like, depending on next step is tough. And there is a pre-pubic hematoma. Then you can try railroading technique also. Put in a needle first. Blood stain. Definitely there is some rupture bladder, except rupture bladder. We open SPC. Okay, SPC has been done. Now we can.
Suppose if you are seeing the patient right now, what options will you give? Whether let go for immediate.
She's asking patient is very stable. You have all the facilities. And you have done a AUG which shows a complete tear.
Have to wait for the hematoma, the cases, other things to resolve, and then the anatomy will become clear for us to go on and operate. There are certain, if there is an impinging bone spicule into the bladder neck, that might interfere with the healing process. So if that is there, then we'll have to immediately intervene.
Anything else?
It's a male patient. If female patients, then we
Male
will.
patient only I'm asking. Come to the later on. Female.
Indication for primary failure. Partial injury, when the injury is partial or just stretch injury is there, but we can try for primary failure.
That will solve the problem.
What is primary alignment? What is delayed?
What is primary alignment? That is immediate impact. Yeah. Any rules?
Star of what? Is it advantage or disadvantage? In what is advantage and disadvantage? Maximum disadvantage in primary repair. Primary repair at the time of trauma.
Disadvantage, more complications will be there, sir. More rates of incompetence and impotence and urinary incontinence.
So we wait and watch. Wait what? 3 months.
He asked what is delayed pregnancy.
We must wait for the next stabilization. After 3 to 7 days, we will do the primary realignment surgery.
The patient is unstable, then resuscitate him, give him enough fluids, blood if necessary. BP, everything is stable, is okay, then after a few days, that's what the delayed primary realignment. What do you use for that? Or rather, what was used for that purpose? Primary realignment. How will you do it? Though results are not that good, in the exam they might ask you.
First, when the patient in the hypotomic position, sir, we'll go by perineal approach. And
No, I'm talking about primary realignment. What will you do? How will you do?
So first, we open the bladder, sir, and we pass it endoscopically. You can endoscopically you can try pass it, try passing guide wire if it is good. Okay, otherwise,
What endoscopy?
flexible
Rigid
cystoscopy.
to flexible scopes are needed for this.
sorry. So now you have endoscopic realignment. That is the, so you have a flexi and through the SPC you put patch your thyroid and try to it and go retrograde also the cystoscopy and you try to fix that. When you are going with the open, now right road is subslate. It's not, we are not doing. Once upon a time, that is the reality what we were doing, not now.
Scope flexible and not available, you can use the sounds, you can use your urethral sounds, you can use.
Should not use. He'll make more trauma, more harm than good. Better not to use. Go ahead.
So how will you approach this case? Now patient has been put on
Know the findings, you know? Yeah.
and he's on SPC for the past 8 weeks. What's the ideal time for you to take up the patient for that delayed effect?
3 to 4 months, but it's a bit delayed till 8 months. First, we'll again reassess the patient with the history, and again, we'll do ED everything. Then we'll go for a up and down ureterogram, and again reassess the exact. Then
It is up and do. When
Usually go with the up and down ureterogram, right?
Don't go straight away.
Straightly you go for an opposing ureterogram.
we'll go RG first.
You do a X-ray. Why do you want to do a pain X-ray?
To roll out the stone, and second the status of the fracture now. Any
Yeah.
callus to roll now.
Yes. Then we'll go ahead with the.
First RG, then followed by appointment.
So they had done a both. What you asked, it has been given to you.
The contrast image command MC with RGU showing a blind ending defect at mid vulvomembranous junction, approximately around length of around 1.5
You
centimeters.
do the MCO initially or you'll do RGU.
First, we will instill the dye through the upper SPC, and we'll ask the patient to avoid so that the bladder neck opens, and parallelly we push the
Anything you will give an additional thing for the bladder opening?
alpha blockers you can give.
When will you give?
Just before
Half an hour back?
no, no,
Half an hour before?
night before the planned procedure.
At least.
Have you ever asked a patient while doing a ureterogram, simultaneously to ask him to avoid? Have you tried that any time? Is it very easy? Then
Difficult.
it's not possible here. Now you ask, you inject some contrast in the urethra and ask him to avoid. How it's possible?
So for the bladder neck only you are giving your alpha blocker.
Do ureterogram,
Yes.
then do a cystogram. Ask him to do avoiding cystogram. Just ask a patient, inject contrast in urethra. Ask him to avoid, do the bladder contrast. Ask him to avoid. He's not able to do it. He's never able to do it. Give him camera, do ureterogram. What is the purpose of doing cystogram or what are avoiding cystogram? MC.
First to know the opening of the bladder neck, sir, and know the proximal part of the prostatic urethra, and the exact gap between the proximal distance extent we will be able to know, and in associated bladder neck injuries, see the counter of the bladder at that time also.
His bladder neck is open by doing a plain cystogram. Indicates what? Bladder neck is open. The plain cystogram. Then only ask him to avoid. What does it indicate? Bladder neck is wide open.
Incompetent
Bladder internal sphincter. So should be careful. Okay? Show the incompetence of your internal sphincter. So what is the site of injury?
It looks like a voluminous junction injury, sir, with mild extension towards the bulbar part, with around length of around 1.5 centimeter approximately. blind ending.
Okay, how will you proceed then? Now you got up and down ureterogram or opposition ureterogram. The bladder neck appears to be open, and the proximal prostatic urethra you could make out, and vulvar urethra is blind ending. So it's roughly around 1.5 to 2 centimeter. How will you plan and what will you do?
First, I will explain the patient regarding the procedure and the post-op expected complication out of it. And since he's a male, the perineal
Plan regarding
end to
this
end.
patient, where is the, do you think where is the site of the thing? Is the bulbar plain bulbar or is the bulbar membranous or is the peripheral?
Bulbar membranous is slight extension towards the bulbar.
Why you say it's a bulbomembranous?
So it's at the lower part of the level, sir.
Lower part of operator.
How will you know this is operator internus?
Foramen, sir. After the foramen lower part.
You come below that.
Well, below the urogenital diaphragm, right? So what is your plan? You have to explain to the patient.
I will explain to the patient that patient
What are
require a
you going to
reconstructive
do?
surgery, primary end-to-end anastomotic urethroplasty. Explain to the patient.
Yeah. Okay. So what are the complications can occur?
Complications,
And if you are unable to go beyond, what are the things you will do it?
So I'll explain regarding the starting with the perineal approach. The patient might require, if not possible to get length into the further added procedures required. The post-op complication as ED and re-stenosis chances, stricture and further.
All the next. How will you proceed for surgery? And counseling will do. He'll say what a counseling is, he'll agree with you. How will you proceed with the patient? Under what anesthesia position? How will you proceed? Patient on table.
Patient under
lethal
anesthesia. Patient under anesthesia, sir, with the high lithotomy position.
High lithotomy position means
extended dorsal flexion. Extended dorsal flexion.
external lithotomy.
So it gives a good approach.
Why not social lithotomy position?
It gives a good approach the perineal. So
Do you have any evidence to support extended lithotomy versus social lithotomy? You have to justify. No? You said you are planning to put him on extended lithotomy. Why do you want to put him on extended lithotomy? Why not social lithotomy?
Anybody else?
The current recommendation, the classical extended lithotomy is not required, sir. It does not give a better exposure than the social lithotomy.
Then put the patient position. What is required is your upper border of the stricture, proximal under stricture. You would identify before going into procedures. We'll keep various options of surgical procedure open in the mind. Put the patient in social lithotomy position or modified external lithotomy position.
So we'll go by the perineal approach, you know. How will you do it? Inverted U shape or vertical, what is the proposed incision?
Go by vertical incision. Go by vertical incision. First thing, we try to identify the upper border of the thing when we go in, no? We almost on the upper area. The steps is we put in inclined incision, dissection will dissect the subcutaneous fat, then bulbous spongious muscle will be identified, open in the midline. We'll mobilize the entire bulbar urethra, and then we'll try to go proximally up. At that point, complete mobilization of bulbar. Yes. At that point, we'll have to try to identify the proximal part. So at which part? So then we'll have to either try to use a sound, urethral sound to the SPC.
No. You'll be dissecting the bulbar urethra.
Yes, sir.
You'll go up to the
Uniscrotal junction.
no. Uniscrotal junction is your distal, proximally.
Proximally, how far you can go with your mobilization of the bulbar urethra and mobilized.
Triangle. Close separation. That is.
No. Those things are all for the proximal end here. For the distal, we were talking now. You'll go up to the stricture. If the stricture is
See, you look at your triangular ligament, then you can go near that stricture part. You can, very well up to that, you have to dissect very nearly. Then only you can have all other steps to get your proximal part. So till this dissection itself, you can go ahead with it. You can reach your stricture part. Then what will you
You pass a pipe Foley's to through the venous to know the limit of transection of the urethra.
okay.
So that
Either a Foley or a sound, you can use that. Yeah. Yes.
Real time you can feel it whether you are in the scar tissue, dissecting on the scar tissue or something.
How will you identify the part?
So here you'll go to the normal urethral mucosa and then divide it, and then do a spatulation if you want now, and then keep it away. Then how will you proceed? Then what will you do?
proximal urethra has to be dilated.
Dilated.
How will you identify your proximal urethra? How is the stricture posted there along with your proximal part?
Put a flexible scope from our up to the.
Now you have a flexible scope so that you can easily, otherwise if you put a scope, sometimes your posterior part of the bladder itself can indent and that can be falsely, it can be as a urethra. So you can now, as you have a flexicysto that you can, and you can identify your proximal part. Okay. What will you do?
You don't have a flexiscope. Then what will you do?
Sound can be used or
What sound?
A groups.
E-grooves. Okay. E-grooves with the opening also is there, so that through that you can pass still at also. Okay. You can feel for it in case you don't feel, because of dense scar tissue.
No, hence scar tissue is there.
Dental tab can feel any impulse of the sound.
No. Let the proximal part and the urethra, whatever comes next.
See the light of the.
You see the light can touch. You can cut all your scar tissue.
So excise your scar tissue, go in the plane, and then try again with the scope or with the sound.
Purpose of doing urethroplasty. What is the results?
The scar tissue must be totally excised, then only your result will be good. Okay.
Retention free. And you should not, patient should not get any body. All these things should be avoided. So what are the things you'll do after cutting your scar tissue? Still you are unable to get your proximal part of the urethra.
Corporal. Pleural separation. Inferior pubic. Corporal.
The thing is that the proximal end, you must be sure that it's devoid of all the scar tissue. You have to go even up to the verumontanum. You have to see the good mucous membrane all around. So at least 1 centimeter or 1.5 centimeter all around, so that you can take a bite properly. You have to dissect, which is not that easy. You have to go slowly, gradually, gently, without damaging the rest of the structures. Okay, now you have cleared all the scar tissue, and you have gone almost up to the verumontanum. And here it's the bulbar urethra, probably a distal bulb. I'm not talking about this case. So you are trying to mobilize it, you are mobilized up to the scrotal junction. But even then, you feel that there will be tension or there will be cardia. And what do you do? Start oral separation. Up to what level you can do? You can go up to the pelvic bone, the pubic symphysis. What will you see there? You separate the corpora separately. In that area, what will you? Dorsal vein of, yeah. That you'll have to ligate and divide. Otherwise, will be hectic bleeding and you won't see anything. Okay. So even then, there appears to be some tension. What will you do? Inferior, not total pivotally, inferior pivotally. How will you do it?
Take a wedge of lower half, you take the wedge of just half lower.
Now, wedge is the total pivotally. Here, what instrument do you use for pivotally, inferior pivotally? That's not that easy with a punch you can do. Wrong, a curved instrument. Have you not seen this? Gooch, yeah. So with that, you can do the hammering. Callus.
We kindly request the examiners to use the mic, but the students at the behind are not.
Callus, you should take care of the callus. That is the main thing which will be obstructing your way. So you have to remove all the callus along with your inferior pivotally. Then what will you do?
Still, length is not possible, then you will do the corporal rerouting will do.
Can you do?
Urethral rerouting.
What is done here?
What do you do in the rerouting?
So we'll, after total separation, we bring the corpus conjugum behind the corpora cavernosa and we'll.
Behind one of the thing, laterally you'll have to bring it, so that the distance will be straight and short. Nowadays they say the corporal rerouting is not that beneficial, just separation and inferior pivotally. Majority of the cases you can do a good anastomosis. In the event that the proximal prostatic urethra is totally plastered in the posterior aspect with the scar tissue, a lot of hematoma would have been there, which has healed with a lot of scarring, and you are not in a position to mobilize the proximal prostatic urethra. What will you do? Yeah, then you can go for a regular pivectomy, and then
End to side anastomosis.
talk through the mic.
End to side anastomosis.
How? End of the vulvar urethra
Directly to the prostatic.
and anterior aspect of the prostatic urethra. You either put a sound suprapubically, lift it up or tent it up, make a elliptical incision, and then you can do anastomosis over a silicone foley. Ideally, you have to do a end of the vulvar to the end of the prostatic urethra. So in the event that it is plastered, and if you do the dissection and try to pull it out, you damage the thing, the vascularity, everything gets compromised. In that case, you can do that. It's the last resort which you can do.
Can you do that without removing the pubic chunk? It's a whole old method. Take a chunk of pubic bone, giggly soft. It's all. What is the procedure called?
Waterhouse.
Waterhouse.
Superior pivectomy alone can be done.
Without that, you cannot do end to side. So you have to definitely you should do a Waterhouse, but not necessary. Now I'll tell you one thing. You put in a sound. suprapubic. How we go is, suppose you immobilize that distal stricture portion, cut it off. Proxima, I put a sound. Sound I'm able to palpate. I'm fine. Suppose you're not able to palpate only, then forget. Then you should plan for all the rerouting, everything. It gives a clear-cut idea. You put in a sound, don't incise it over some anastomose. You put in a sound, it's very difficult to, that means it's a difficult high stricture. Then you plan for all these methods, what people have said, pleural separation, or suppose easily palpable, then you can cut the scar stricture, then mobilize around the urethra and into an anastomosis. Suppose you're not able to feel the sound suprapubically to a scar, to the wound, then you have to plan all the alternative methods of to localize the proximal end of the urethra. What else is done is ultimate, where they do they take a chunk of bone, put in their cavity, put in a momentum. What else is done? Now their inferior pubectomy gives as good result as.
You have done a proper, this case what you have done?
End-to-end.
End-to-end anastomotic arthroplasty. How will you follow it?
The post-operative period, once a drain volume is less than third day, second or third day, we remove the drain. Then after that, catheter is left for at least 21 days. Then after that, we do catheter removal and VCUG. VCUG can be done.
Why VCUG? 21 days, we are going to remove it. You can put a scopy and you can see. Nowadays, when you are immediately after doing the anastomosis, you can put a scopy and see whether your alignment is good or not. So 21 days, you have waited 3 weeks. You can put a scopy and see whether your caliber is normal or not. Then, what is the incidence of recurrence rate in a post-traumatic urethroplasty, end-to-end urethroplasty?
Restenosis rates 5 to 15% restenosis rates are there.
5 to 15% if you have done a very good urethroplasty. Okay, it is less than 5%. And what is the rate of your ED, rectal dysfunction?
30 to 40%.
50%.
Another some important steps are some tidbits. The proximal end appears to be a little ragged, and you're not sure whether you're going to make a proper mucosa to mucosa anastomosis. Probably you can take mucosal tag sutures and avert them, either both in the proximal as well as in the distal. And then if you do the anastomosis, that will be better. The mucosa to mucosa anastomosis will be there. Then the chance of recurrence of the stricture will be very, very less. In case you are not very sure about the proximal end, you are putting a sound, you don't have a flexiscope, put in a sound and you feel that, and you make an opening, but you are not sure whether you are in the false passage or not. What will you do to know that you are in the right track?
We can put a methylene blue and see.
Even through the false passage, methylene blue will come. You can put in a scope and see through the opening, see whether the value is there, whether you are going through the bladder neck into the bladder or not. That you can see on the table. You can do it. Even with the rigid, you can do that. And then you can do the anastomosis.
What is the commonest cause of restricting? I've done a good urethroplasty. What is the commonest cause of?
Not exercise fibrosis, but completely.
How do you know you have exercised that?
Stricture completely. Intraoperatively.
Intraoperatively, the mucosa is freshly bleeding the edges, and it looks pinkish, not a pale mucosa. It will not be there.
Supple pink urethra. There should not be any scar tissue.
As we are dealing with a traumatic stricture, going back, patient has come to you. What are the conditions you'll go ahead with the primary primary repair. You have some conditions, no, that you cannot put all the cases under SPC and for 6 weeks or 8 weeks, go ahead with. What are the conditions? You'll go for a primary repair. Yeah, female, children, and associated other injuries. When you have other types of injury, bladder neck, associated bladder neck injuries, bladder injuries, or rectum, colonic injuries, then you have to go ahead primary repair. All these conditions, you have to go for a primary repair.
Okay, you have done a good mucosa to mucosa anastomosis. Even then, after catheter removal, patient is avoiding urine for some time. Then he goes for slow stream, and on evaluation you find the stricture recurrence. What else could be the reason? You exercise all the scar tissue. Ischemia to the vulvar urethra. Yeah. That's one of the reasons why stenosis can happen again.
Yeah, done well. Stricture ultra is a common simple case.
And then post-operative,
Awaiting.
what about the Euroflow?
Will you do a pericatheter contrast study? Given us now, yes. Now you do a MCU and see the lumen proper, which is,
Euroflowmetry and doing
yeah.
Euroflow normal, we repair MCU. Camels, you talk only camels.
Suppose patient is having a restriction, what will you do? After doing your hyperineal end-to-end arthroplasty. That is one question. And patient is asking complaints of VD, erectile dysfunction. You have to answer for that. You have to do something for that. What will you do? So restriction, what will you do?
You assess the stricture.
You assess the stricture. If it's very short stricture, what will you do? You do again a ureterogram and you do assess, and you can go ahead with the endoscopic management.
Or the vision ultraplasty.
If it's very small, less than 1 centimeter or 0.5 centimeter, you can go ahead with the endoscopic management and asking to go for a self-dilatation. Okay. And about erectile dysfunction, you have to assess. Then you have to know how will you assess the erectile dysfunction, what are the things and what is available, what treatment you will be given.
What is the cause of erectile dysfunction? Two things, one is vasculogenic and neurogenic. Not vasculogenic, shortness. Most vasculogenic.
Mostly it is because of
Most.
both or direct injury to the cavernosum or hydrogenic after that.
It's a separate chapter. Well done. Good job.
Okay.
Thank you.
Thank you.
Thank you very much, all the faculties, for the wonderful discussion again. May we have the next team on the stage? May I request Professor V. Kamaraj? May I request Professor Kamaraj? Former Professor of Madras Medical College. Dr. Stevenson, who is currently doing a wonderful job in Proton. Dr. Stevenson trained in uro-oncology. And young and upcoming cricketer. Professor Kripanan, all-rounder, Dr.
Hardik Pandya.
Thank you.
This is going to be one of the commonest case that you see in clinical practice as well as in the exam.
A 67 years old male, farmer by occupation, presented with the main complaints of hematuria for the past 3 weeks, which is total, gross, painless, not associated with clots. And no history of dysuria, no associated fever or vomiting or loin pain, no history of obstructive or irritative LUTS, and he had no history of pyuria, calciuria, and chyluria, no history of loss of appetite and loss of weight, no history of dyspnea, chest pain, back pain, and jaundice.
Anything else in the history you'd like? Anything else in the history that you'd like to ask? What is the significance of the total gross painless hematuria not associated with floods? Does it signify anything or is it just written as a?
Also, it signifies.
What does each of this terminology signify?
So gross painless hematuria more in favor of malignancies, it's a CA bladder. If it is associated with the
Don't say CA bladder. What is it?
urothelial carcinoma. And then if it is associated with the pain or something, it can be clot pooling, sir. It can be from upper tract also, sir.
Okay. And what do you mean by gross? Total hematuria.
Total hematuria can be from either from the upper tract,
What do you
from
mean by total hematuria?
throughout the stream, sir. It is present throughout the urinary
So
system.
when you get that, and what are the other types of hematuria that you know?
It's an initial hematuria, sir. It's usually from the urethral lethargy due to inflammation, I think. Total hematuria can be from the upper tract or from the bladder, sir. And then terminal hematuria, usually from the bladder, neck, and the prostatic hematuria.
So, right. So what, they say it's not associated with clots. Why do you think so?
So it can be, clots can be of, whether the source, whether it can be upper tract, you can get the serpiginous clot, sir. There is a serpiginous clot, sir. As if it is from the bladder, it can be the amorphous clot, sir.
Have you heard of the terminology called Herald hematuria? Herald hematuria is usually an initial episode of hematuria which is usually missed.
Okay.
So you herald that this thing before that. So you have to ask history of that. Because have you missed any previous episodes of hematuria?
Okay.
One important personal history is I don't know whether it's coming in the back. What are the other risk factors that you will ask for in this case of
Smoking, sir.
Any other tobacco?
Occupational history also, sir.
What is significance of occupation?
So exposure to dye, leather industries, certain aromatic amines.
So it says farmer by occupation,
Yes,
very
sir.
significant.
Pesticides, sir.
So I mean, may not be clinically all these questions may seem a little irrelevant, but as an exam purpose, you should know all these things as a basic. You can go.
No history of comorbid illness, no history of surgeries in the past.
What is the significance of diabetes test? Do you know of any significance with relation to urothelium?
So that's on drug pioglitazepine, sir.
Personal history. He's a non-smoker for past 30 years, 10 to 12 cigarettes per day, non-alcoholic, is on mixed diet. No history of significant family history.
How do you calculate that? How do you put it as a known spectrum in your histrication? Do you put it like 10 to 12 cigarettes per day, or is it, what is that?
Pack index, smoke pack index.
How do you calculate that? You have to go read that and find out, because that's something that they'll ask. Okay, good.
On examining the patient, he is conscious, cooperative, well-oriented, moderately built, paler, and anectric, afebrile, no cyanosis, hydration is adequate, no bilateral pedal edema, no lymphadenopathy, vital stable. On examining the abdomen, all quadrants move equally with respiration, no scar and umbilicus centrally placed, no palpable mass, normal resonant abdomen, bowel sounds present. On local examination, external is adequate, penile shaft normal, scrotum, testis, cord structures normal. On rectal examination, tone normal, grade 1 prostate, firm, smooth, non tender, non-nodular. On systemic examination, normal findings.
This is the case that's come to you. How do you proceed?
I'll go for
Summarize a single line and
63 years old male who was a smoker and a farmer by occupation with complaints of total painless hematuria for the past 3 months with No other positive finding or anything, sir. We will often TD, sir.
Pallor, pallor is-
Pallor.
anything else? And what will be your differential diagnosis with this history and exam?
So first I will go for carcinoma bladder, urothelial bladder carcinoma, sir.
And then say urothelial cancer, probably from the blood.
And then upper tract urothelial UTI, sir.
Okay.
And then also renal cell carcinoma also can one after DDA will put, sir.
Okay.
And then bladder stone, sir. Cyclical also.
Okay. Anything else? What is actually the commonest cause of hematuria in the public? As a general rule, if a patient walks into you, 5 out of 10 patients will have this. What is it?
Say asymptomatic.
Okay. Medical causes. Okay. I'm talking about other causes. Yeah.
UTI, sir.
Okay. UTI and prostate is the commonest cause. So, what will be your next TD for that? If you have crossed all those things.
BPH, sir. And then severe prostate also I put in the last.
So these two things, don't forget to put it in the DD. Okay. Obviously, these are not the case, but then we have to. Okay. Then how would you proceed for?
One second, sir. For drug history, I don't know whether it was mentioned.
Anticoagulants,
Anticoagulants and elderly, yeah. Diabetic biochemical, yes, that is there. Also in diabetics, renal papillary necrosis also can lead to hematuria.
Okay.
Anything pertaining to young males presenting with hematuria after going to gym, what is that called?
The trans.
It's not related to
Also,
this case. Exercise hematuria also you should be aware. We will go on. And about one more type, sorry, one more type is cyclical hematuria. Where do you see that?
The second fistula.
Bladder hematuria is common. Okay, we proceed.
How will you proceed with this?
So I will go for ultrasound and abdominal pillage since it's an extended part of clinical examination and it's non-invasive and we'll go for ultrasound and abdominal pillage.
So one of you kindly.
Next.
Sure. So can somebody read this ultrasound in series?
Right. In the previous cuts, bilateral kidneys appeared normal in shape and position. Concomitant differentiation was maintained. In the this is image of a partially distended bladder. Bladder wall thickness cannot be appreciated well, but broad-based, solitary around maybe 3 to 3 centimeter broad-based lesion is noted on the at the area of the bladder neck and right lateral.
There's no scaling there.
Anyway, you can't say. Just say what you
Solid,
see.
yes.
Yeah. Okay. So what type of, what kind of a lesion you feel it is? How will you characterize this lesion? One, you said location, the size.
Size.
Size. Okay. Then what else?
Broad-based,
Broad-based.
solitary,
Sessile
sessile
or-
lesion, sir. Vascularity is not.
You do the
shown on
Doppler
this
to
cut.
look for the vascularity. Perfect.
No other lesions are appreciated anywhere else in the
How will you
bladder.
differentiate between the cloth and the tube?
One would be the presence of vascularity, other would be change in position, which we'll do at the time of the scan for us to assess.
Right. These will all become very basic. Okay. Right. So anything else? Now this is the case that you've had. How will you proceed further? This is a solitary around 3 centimeter lesion that is C with hematuria and pallor. This is the case. How will you proceed further? Would you do further
I would like
investigation?
to, yes, sir, I would still like to do a contrast enhanced CT.
Why?
This patient
For
is a
and
smoker.
against.
So for would be, one, this is a broad-based lesion, sir.
Okay.
Second, he's a smoker, so the chances of him having associated upper tract anomaly.
To rule out
Normally, it is 4 to 10%, sir, but in a smoker, the chance. EAU guidelines to do a upper tract.
So what does the
imaging
EAU
unless there
guidelines say? What should you do next?
So urine cytology also we'd like to, sir, in and see whether it's whether the urine cytology is positive or not. If it is positive, we are seeing if it's high grade or not.
Now, if the urine cytology is positive,
Positive,
what
then
does it
most
indicate?
likely- most
It
likely
is
it's a high
probably a high grade disease. If it is negative, does it signify anything?
No, sir. The urine cytology negative.
Okay, so we have done cytology, we have done ultrasound. So according to guidelines, ideally, this is a case where you, but as you rightly said, since we have the facility of a CT, what kind of a CT that you do?
Contrast enhanced
CT
CT of
Europe.
abdomen with delayed imaging.
assume that the upper tracts are normal. Okay. So one of you can just give me a brief report of the scene. What did you look for and what is the finding?
We'll see for filling defect, we'll see sir, bladder thickness and filling defect. So it is only single, like our same like filling defect is seen at a single legend around less than 3 centimeters, around 3 centimeters.
Don't bother about the size.
And we have to see for nodes, anything we have to see, and extra caps, any extra bladder extension thing.
Stay in the bladder mass, finish the bladder mass and then go for the nodes. All you will see in the bladder mass and elsewhere. Then go for the nodes is the last TNM. Finish the T.
Any pelvic extension to extra bladder and pelvic, anything extension.
Extra bladder, extra vesicle. So what will that become? T3.
T3.
Right. Go ahead then. Keep the same thing. Size, side, number, and
single.
Again, sessile or
sessile
polypoidal. Okay. Then anything else? How can you rule out leiomyoma sericea? Is it a leiomyoma or is it a urothelium? Anything else?
Enhancement. There will be minimal enhancement in leiomyomas. And homogeneous pattern in urothelial carcinoma. And it will be large size, urothelial outcome.
Anything else?
It will be more lobulated. We had recently one case.
It will be arising not from the mucosa. It will look like arising and pushing the mucosa away. Chances of hematuria is also very less, but then it can occur if it erodes the mucosa as well. So it's not like it cannot have hematuria. Usually the patient presents you with hematuria. Otherwise, it's incidentally picked up. Right. Okay, so where will we? Yeah, then what else you will look for in the CT? Notes, then what else? The most important thing that you have done the CT for?
Upper tract, any is there and any lesion filling defects in the ureters.
So what does the H1 signify? Why are you looking for the H1? That should you have looked off in the ultrasound as well.
Yes. It's near, if it is near the ureteric orifice, look for orifice involvement.
Okay.
Or,
so what are all could be the causes of an H1 in a case of a TCC of the bladder?
T2 lesion near the ureteric orifice,
okay,
or distal ureteric tumors.
Okay.
And muscle with T2 lesions.
Fine, right. So where does it look to be located according to the image?
Posterior wall near the right ureteric orifice.
Looks bang in the center to be, but
Center,
yeah, okay, fine. So it looks near the trigonal area, so it's very essential that you look for this thing. Also, you have to look for the other lesion in the urethra as well as in the prostatic area as well, because it is multifocal generally, right? It's a field disease.
Yes.
Right. Okay. Then what? Now this is the finding. This is the patient with you. What are you going to do? Done all the investigation necessary, all preoperative, everything is done. How will you proceed?
Talk about the notes. Notes, yeah, oral context.
For all practical purpose, let's assume it is probably T1 by T2, doesn't appear to have gone extra vesically here, looks clean, and for for all practical purposes, no nodes. So this is the patient. How will you proceed? Do you like any more imaging? Do a PET CT, do an MRI?
No, at this stage, no.
Why? Why not?
T1.
What is the percentage of distal or nodal mets with the T1 disease and a T2 disease? According to the guidelines.
5 to 10%.
5%. Okay. So yeah. So there is a chance, but we don't do it. According to guidelines, the next step would be
Bimanual examination with cystourethropy.
So you will take it to the OT and do what? Can any one of you just enlist what you are going to do? Once you are inside the bladder or what doing cystoscopy, what all will you do? Just enlist 10 minutes.
Preoperatively, we prepare the patient very well. I mean, anemia, we need to correct the anemia.
Okay.
HP more than at least 10. Keep blood products reserved and talk to the anesthesia regarding general anesthesia.
What is the anesthesia that you're looking out for here?
So general anesthesia we look for or spinal anesthesia with
So I'm assuming that you all guys know how to give a obstructive block. I'm not going to ask that. Okay, right. So what type of general anesthesia are you talking about? LMA?
Interpreted, like endotracheal.
So I'm looking for a certain terminology that I'm going.
Muscle paralysis.
Neuromuscular blockage. Okay, that's what you're looking at, right? Right. Then what else?
Then
Any other preoperative thing you should know? Nothing. Go ahead. Then patient is induced, neuromuscular blockade is given. What will you do?
bimanual examination and then cystoarthroscopy.
So 1 day prior, you can keep them on pyridine because the tumor is back in the center. Okay. Sometimes to know whether urinary orifices are involved, you can add pyridine 1 day prior. 200 milligram. Yes, okay. Okay, go on. You're given general anesthesia with neuromuscular blockade. How do you assess the bladder?
Bimanual examinations are Marshall staging. In case of T2 stages, it varies. There won't be any palpable mass. If any
bimanual is done in full bladder or empty?
Empty bladder, pre-op and post-op both will be done. Then
So just
cystoarthroscopy
make sure that the bladder is empty before you do, otherwise you'll be sick. Okay, sir.
and then proceed with TURBT.
No. Proceed with what? Scope.
Cystoarthroscopy and then
What will you do in
identify
that?
the lesion. How far is the lesion from the curative?
Step by step, how do you go about doing? So what is bladder mapping? It has to be
Bladder
done properly and documented for future purposes as well. So how do you go about it? After local anesthesia installation, you will put in a scope and you will look into all parts of the urethra, go on to the prostatic urethra.
Prostate,
Yes.
bladder neck,
Bladder neck.
then triangle, posterior wall, and lateral walls.
What all you are
anterior
looking
dome,
for? What are all the things that you will note down? What are, I think the same thing.
Urinary
Site,
orifice, size, shape,
number,
or number,
not same.
relation,
Yeah.
and
Broad-based, yeah.
relation to the urinary orifice.
Okay.
And any else where like any tumor or CAS patches.
Look out for CIS. That's the most important thing that you're gonna look for. Why? Because it drastically changes the treatment modality that you're going to do.
I agree.
Then what will you do after that? You've done all this documented, then what will you do? What kind of energy that you're going to use?
In our institute, we use monopolar energy also.
Monopolar energy.
What is the blind area in the bladder where you have to be very careful?
Dome, anterior wall and dome, and
Close to the
close
bladder
to the
neck.
bladder neck. Bladder neck.
So how can you visualize that area?
At the left. So, pressure. One mode is like pressure in the dome, and look at the left close.
Partially, don't fill the bladder.
You don't feel too much. And turn your telescope upside down.
Yeah.
If you have a 70-degree telescope, that is best, right? What we usually have is 30 degrees. So turn your scope upside down and then someone to press from above. In addition, if you have one more instrument, apart from a rigid models will be helpful. Flexible scope. So you need to do the Jane maneuver, go up, look from above.
So would you do a preoperative flexible scope for this patient?
You can do flexible scope.
Clear-cut imaging showing a tumor lesion, we don't do unless you're not sure about what is the cause of hematuria. But generally, actually, to be fair, the NHS protocol is to do a flexible, document the tumor, and then take him up planning. But here in India, we don't do that. We directly go for cystoscopy and proceed. Right. Then, what else? What energy you said? Monopolar. Okay. Okay. What are the other types of energy that you can use?
Bipolar.
What is its advantage?
We can use saline as a ligand and clean piecemeal. We can avoid obstructed jerk also.
Not so much here. Yeah, you can still have it. Yeah, okay, fair enough. Then it reduces the incidence
Reduces
of
the incidence.
not completely upgrades. Then
Absorption, not much. Not
Chances of
absorption,
TR.
not much. It's not
anyways you won't
readily
have
used.
much unless you have a perforation or something. Okay.
Charring effect also is less.
Charring
So
effect,
you get a
clean
little better
piecemeal, clean
prognosis.
piecemeal.
Okay.
For
So,
sure.
is there any other method other than TRBT to do this removal of the tumor if it is possible? What is that if so? More pathologically better.
Laser.
Laser?
What is it?
En bloc dissection. So what is that?
In solitary less than 3 centimeters, single tumors, the whole of the tumor itself may be, the attempt would be to remove the whole tumor in one swipe in order to send and keep the
So
tumor
what is the
active.
layer that you reach and then you re-nucleate it? You go down to the muscle layer,
Yes, sir, we have to-
superficial detrusor,
And then
incise it along the superficial detrusor, remove the tumor in toto. How do you remove this tumor out then? No, how will you remove this? The main point, for purpose of doing the surgery itself, is to remove it in toto. So you will have to have a sized tumor that you can remove within your sheath. You can either use a grasper or you can use your stone punch sheath or something like that to remove. But it has to be removed in toto. Otherwise, you can't again cut it into piecemeal and then remove it as well. You can also do this with the help of your monopolar or bipolar energy as well. It's also documented. You can use your Collins length also to make some DRPT. How will you ensure that the muscle is not missed while you're doing DRPT? Many times you get a biopsy report saying that muscle not present. Make sure.
we'd like to send it separately so that the pathologist knows the area of the deeper dissection and they'll specifically look for the muscle at the time of stem.
So you will have two specimen bottles sending the superficial tumor as well as the deep resection margin in order for us to be sure that they look into the muscle part of it. Where will you find the difficulty in doing this kind of resection?
At the area of the dome, the chances of perforation may be higher when we are trying to dissect deeper. Hence, or in the
Lateral.
lateral also, sometimes because of the operator jerk, there may be a
So that's why we always do under neuromuscular blockade. We don't do it at the non-neuromuscular blockade because you will land up in issues later. So if you have an anterior wall tumor or a dome tumor, how are you going to go about doing this TRP?
we can use the help of a mowing loop, which will help us, especially in the area of the dome, which will help us to
Okay. Should have a partially filled bladder. You can use the loop. You can use your normal loop, slightly bend it forward so that you have this kind of scissoring effect, and then you can remove it. Right. You have done that. You have the biopsy report. I think we're running out of time, so let's move on. Yeah.
Quickly, can you just enlighten before that? How do you prevent this operator jerk? I think most of you have told one. Okay, anesthesia, second, partial filled bladder. Then
short bursts of
okay, short bursts, short quick bursts of
partially
keep your current low. Your cutting, keep it low as low as possible.
Which causes operator jerk? Cutting.
Yeah, coagulation process and CVS have also described. I don't know how keeping your the electrode, your neutral electrode to the opposite side, and finally ask your assistant to hold the lid. Don't believe your mistakes. Go on. A biopsy is come as low grade papillary urothelial carcinoma with no evidence of infiltration.
It's a THG1 relation, sir. Low grade THG1 with no lamina propria oxidation. So it's a THG1 relation.
THG1 or T1G1?
It's a THG1, sir.
Okay, then. What is your plan for this patient?
THG1 following the sisters.
Is it really correlating with your history and all those things that you've seen and then the biopsy report?
No, sir. It's a broad-based lesion.
I would ask for a review, but anyways, let's go on with this. What is your plan for this patient once you have this? Would you have done an installation of mitomycin C for this patient or not?
Yes, sir. Yes, sir.
How did you decide that?
Within 2 hours.
What guideline did you use for this? What is the score that you did for this? EORTC.
Organizational process.
What is the criteria that you use?
Size less than 3 centimeters, papillary, single growth, no multiple.
Not near the orifice. Right. So what is the dosage and how do you give
40 milligrams per 1 hour, sir. It has to be given within 6 hours. It can be given up to 24 hours, sir.
Intra or post-op within 6 hours, provided there is
no perforation, there should be complete resection, no hematuria.
No bleeding. Why?
Sir, it can be absorbed and it can cause sepsis.
Sepsis. It can cause toxicity, including seizures. So you have to be careful. So what? Yeah. So easy to remember is 40 mg in 40 ml of saline for 40 minutes. So easiest to remember. Right? Okay. So you would have given it this patient, right? So after this, what are you going to do for this patient with this biopsy report and then another biopsy? What do you do for follow-up? You're going to do some intravesical installation or that's it?
No, sir. No more.
Only surveillance.
Only surveillance.
What is the surveillance that you're going to do? For how long?
369. Only like at the end of the.
Is it 369 now or 3612 now?
3612
now. Okay. So only 1 year.
And yearly after for 5
What
years.
option?
For 5 years.
5 years for a low grade papillary.
3 years.
High grade 5 years. Okay, right. Then what are you going to do for follow-up?
Urine cytology and cystoscopy.
Cystoscopy then?
And ultrasound and routine investigation.
Everything every 3 months or how are you going to do?
3, 6 and then
When will be your first flexible cystoscopy?
3 months.
That is the most important, one of the important criteria. And a recurrence at 3 months is the worst prognostic factor for this thing. Okay, now forget this biopsy report. You have a high-grade papillary urothelial without evidence of infiltration into smooth muscle. What is your plan?
BCG installations.
Directly. No need for ETRBT.
We need to look for re-TRBT if it was a.
You are the primary surgeon and the patient has come back to you only. You know
Sir.
that you have done a very good job in the first session. What's your plan?
If no deep muscle is seen, we'll go for ETRBT. And if any, like if it was incomplete dissection also, we'll go for it. And usually like T1 will upgrade to T2, approx 30%. So we go for re-TRBT after 2 to 4 weeks.
So according to the guidelines, in most 95% of the cases with high grade, you have to at least tell the patient that you have to go in for a re-TRBT. The patient does not agree, it's a different issue. So re-TRBT is a must in all cases of high grade because, as you rightly said, there is 25% chances of upgradation to T2, and that you would have undertreated a disease if you have not done the re-TRBT. So for all exam practical purposes, you have to say re-TRBT as a must for all these cases of high grade. Only for low grade, you don't have to do it. For high grade, all cases should undergo a re-TRBT. Right? You will ask for a re-TRBT. Again, the same thing. No muscle involvement, high grade.
T1 G3, then we'll go
So
ahead.
how do you actually classify the grade of this? Is T1 G3 or T1 HG?
T1 HG also, sir. T1 HG. It falls in
So
high
it's
risk.
low grade, high grade. So that's the latest classification. Again, there is some confusion. Again, in 2023 AU, they said use a mix of T1, G1, G2, G3, and HGLG in order to tell this. For all practical purposes, remember this low grade, high grade. Okay. So T1 HG, what is the next step of management?
We'll plan for BCG installations, BCG therapy.
Okay. How do you go about doing that? What is the steps and what is the schedule? What do you follow?
We follow SWOG regimen, sir. It's weekly for 6 weeks.
Okay. What is the dose?
We follow 120 mg or 80 mg, sir.
You can't say in exam I follow 120 or 80. What do you follow? You tell.
120 mg.
120 you follow. I would say general how advisable is 80. Even some papers say even 40 is enough. How does it act? Why do you think this acts?
BCG, it actually binds to the fibronectin and it helps in T cell initial alpha T cells, interferons, interleukins, and all will be like stimulated, and it will inhibit the angiogenesis. That's how it.
It basically stimulates the local mucosal immunity to kill the cancer cells. Right. So that, yeah. So fibronectin is how it binds to it, and that is how you can follow up the efficacy by doing the urinary fibronectin levels. Okay. Is there any other patient is not willing for any surveillance modality? Like, okay. Is there any other way you can do surveillance other than any urinary markers review has been included in the 2023 AU guidelines? NMP is what not for surveillance. What is the most commonest gene mutation associated with bladder?
NS transfer. Glutathione NS transfer.
Heard of FTFGR?
FTFG.
One of the commonest gene that is mutation. It's obviously multi gene mutation, but this is the commonest, and you can do testing for this urinary. There are 6 tests that has been advised by the EAU. Please go and read them to understand.
Told the BCG dosage can be from as low as 40 milligrams. And what is the reason for that?
So even the recurrence and progression, the severe adverse effects will be lower in 40 mg, and it will be therapeutic or recurrence or progression will be the same as at 120 mg also.
Any other
equal. Lower complication.
Any other logistical reason?
Ice cold storage available.
What are the other protocols you can?
Valrubicin is approved, sir. Then we can still
Have you used valrubicin? What is the commonest that you use?
Gemcitabine.
Okay. Anything else? So it's either, most commonly that is currently used is Gemcitabine. The other one is mitomycin. That is as a regularized protocol of 6 weeks, each week, same dosage and thing. Okay, but the now recent trend is for us to use Gemcitabine. That is easily available and supposed to have, well, it's been approved as well. You know of any other new drug which has come?
BCG unresponsive. Pembrolizumab
Is now upcoming for.
Pembro is approved for this situation.
Please tell me, you have some time, quickly tell me what you understand by BCG failure, what is BC unresponsiveness, what is BC recurrence, what is refractory. You have 5 terminologies there,
Yes, sir.
so you must know all those things. Okay. No, yes, you must know all those things. All of you must know all those things. They'll ask you in the examination about that. Okay. And you must tell me, supposing you have a recurrence after BCG, okay, and you do it yearly, it comes against a low grade tumor. Would you call it a BCG failure or would not call it BCG failure?
Has to be a high grade tumor which is present at the time of recurrence, then we call it as a BCG failure.
Small point which you must go through the guidelines of the therapy, all those things. Okay. And you must know about the alternatives to BCG and BCG failure, what you can do. And you tell me you're talking about carcinoma. What treatment you will not give in carcinoma? For CIS, what treatment you will not do? You have surgery? Or immunotherapy? Okay, so many therapies are there. What is not indicated in CIS?
Lack of resilience strategies.
What is not indicated in CIS? Yeah, it is. This is one of the questions they'll ask you. You must know everything about CIS. And you must know about the different sorts of cystoscopy. White light cystoscopy, blue light cystoscopy, OCT, all those things they'll ask you. Yeah, you discuss about neural vision, part of NMP, neural vision. You must know about neural vision and other things. You must know everything about cytology also. How will it do cytology? You tell me you're not talking about. You tell me how will it be in cytology?
What is the name given to the classification?
This classification.
How will you do it?
Especially ambulatory sample.
Post-ambulatory.
Post-ambulatory.
Why should you take the whole sample? Why don't take just 10 ml sample? Why should you take the whole sample? Why should you take the whole sample?
More sample.
More sample, more. No. Why should you take the whole sample? For example, for urine culture, you take the midstream. Why don't you take the midstream? Why do you want the whole sample? Why you must take the whole sample? Initial voiding, terminal voiding, and also the intermediate voiding. Why? You can have lesion anywhere. Understand? Huh? So you must take the whole sample. Once you gather the whole sample, what will you do? You have say 500 ml of urine. What will you do? The flow is given 500 ml of urine. You told whole sample, he has given the whole sample. What will you do?
Centrifuge.
Okay, then the whole thing is centrifuge, 500 ml centrifuge.
100 ml, 2 bottles,
100 ml. How will you collect the 25 ml or 10 ml or 15 ml, whatever you do? How will you collect it? How will you take it from there? See, these are questions asked in examination. You must be able to answer simple questions. You will talk high and about other things, but you will forget these things. So you have to stir the whole sample, so all cells are mixed, and take 10 ml or 20 ml, centrifuge it, and after centrifuging, what will you do? What will you centrifuge? Centrifuge tube, what will you see? You see supernaturalization and you see sediment. So which will you take? You take the sediment and put it on a slide and put your drop of supernaturalization. And then how do you stain it? These are simple questions. What are other stains available? And what will you see now? What will you see in the slide? So all these things you must be thorough and don't just block in examination. What is the role of flow cytometry?
DNA.
These are all questions which may come to you.
Yes.
Even though it is not practiced, it may come to you. So you must be know how to answer these questions. What is flow cytometry? What purpose are you using? So Now, once you have done this TRBT and the TRBT code has come like this, and you get a recurrence, what will you do? You get a recurrence. You are doing follow-up. People 3, 6, and then 12 you told. Okay. And what will you do after that? Once you get a recurrence? You see the pathology. Pathology shows a progression of disease. What was T1 has become T2 now? What do you do?
We can do another course of BCG can be second because 20 to 30%.
T2 surgery. Oh, it's upstaged and upgraded. Yeah.
Then you have seen.
How much percentage of this low grade TA will progress to muscle invasive? 3%. Okay. It's a very heterogeneous disease. So 3% of low grade TA can still progress to muscle invasive. That's what sir is asking me. Okay. So now it's become T2. What should you do?
Then you go for the patient is fit, then you have to go for radical cystectomy.
This is sort of a deferred cystectomy. So you need to know what happens when you do upfront early cystectomy and for a deferred cystectomy. What's the survival benefit in the upfront cystectomy? That's early cystectomy. So you need to get all those things.
In other words, you will be asked what are the indications to do a radical cystectomy in case of T1 disease.
The non-muscle disease.
T1 disease, not T2.
What indications?
Yeah, what are the indications?
Basically, in fact, is the CA is the T1 G3 is the T1 G3 and then with the lymphocyte invasion more than 3 centimeters. Multifocal.
Yes, next. I'm waiting for a particular one more. Okay, fine. Diabetic lung. Okay, next.
Semantics.
Atypical histology.
Histology. What are the 3 things?
What are the atypical pathologies? No. What are the atypical variants?
Small cell variant, plasma cell type variant, nested clear cell and then micropapillary.
Yeah, this is how the examination goes. Okay, I took some time extra so that you know all this. Okay, go and read these things. Read further so that you do everything. Okay.
Thank you. Thank you very much, sir, for the excellent discussions. May I request directors at the kindly greet our chairpersons in the bouquet, please. May I request the chairpersons of the next session? Professor R. Jayaraman. Professor R. Jayaraman is a wonderful teacher. It doesn't need any introduction. Fireworks will come from the stage for the next 2 sessions. He is going to be there. Professor J.V.S. Prakash and Professor Edith Sundar. So can we greet our persons with the buckets of exam. Thank you, Dr. Giffen, for joining us in a wonderful session. You did a very good program. Dr. Giffen is leaving to Sri Lanka late tonight. So in spite of that, he had come all the way for us. Thank you, Giffen. Thank you. Thank you.
Yes, okay.
May I request Dr. Rajaraman to kindly join the chair, please.
This is a case of 56 years old male who is a farmer by occupation, who presented with the chief complaints of
Right loin pain for the past 1 month. The pain was continuous, dull aching, no aggravating factors, relieved with medications. No issue of vomiting or fever, no issue of hematuria, no issue of lower urinary tract symptoms, no issue of pyuria, calcaluria, chyluria. Past history, no comorbidities, no issue of previous surgeries, no issue of any instrumentation. Personal history, no, takes mixed diet, not an alcoholic or smoker. Family history is not significant. Anjal?
Yeah. We're going to answer. See, he's a male patient. His main complaint is right loin of 1 month duration, which was continuous leaking, and there were no aggravating factors relieved with medications. Apart from that, there is no positive findings in the history. Even so, his main complaint is a right loin pain. So, since this being a long case, so you should have something in your mind. What could be the cause of the loin pain? So, what are the conditions you will keep in your mind as far as this patient is concerned, so that in your clinical examination you can go and examine according to your diagnosis.
Sir, I would like to consider the first differential diagnosis as a stone disease, sir. And second one, any congenital disease like pelvic junction obstruction.
So you go in an order. So at the age of 56, will you think a congenital condition which will produce a pain at the age of 56? PUJ.
So most common 30 to 40 years.
Young age, usually young age, but we have seen patients who present with a large, huge hydronephrosis at a old age group. Okay, first is you will think of a calculus disease. Where is the stone?
So mostly in the PUJ, sir.
Renal calculus.
Renal calculus.
Renal calculus. So number 1. Number 2 is a congenital condition. Number 3.
So I would like to consider RCC, sir. Male patient.
Why do you think of RCC in this case first as a straight away?
Old, 56 years old, sir. Like it is dull aching pain. So I'd like to have the third differential as RCC, sir.
You call it renal cell carcinoma. Why do you want to get histopathology diagnosis? Renal tumor.
No, you will consider, you will think of a renal tumor or some malignant condition. Either it could be in the kidney, or there may be ureter, or it could be in the bladder also. Okay, so you will think of a malignant condition. But the patient does not have any history of hematuria.
Yes.
There is no history of hematuria, and apart from that, of course, lower tract symptoms are also absent in this patient. So malignant condition. So these are the 3 possibilities. You will keep it in your mind.
Yes,
sir. Okay.
On general examination, the patient is conscious, oriented, moderately built. Pulse rate is 78 beats per minute. Blood pressure 110/70 mm of mercury. If patient is afebrile, no pallor, no icterus, no cyanosis, edema, no generalized lymphadenopathy. Cardiovascular system is normal. Respiratory system is also normal. Central nervous system is also normal. On a per abdomen examination, inspection, all quadrants move equally with respiration. No scars or dilated veins present. Palpation, no mass palpable on superficial or deep palpation. Percussion, normal resonant abdomen, no free fluid. Auscultation, normal bowel sounds heard. External genitalia, external meatus is adequate. Pepper is normal. Glans, shaft, bilateral testis, and scrotum normal. On digital rectal examination, anal tone is normal. Prostate is flat, smooth. Rectal mucosa is free.
Okay.
Sir.
So your clinical examination looks
normal, sir.
Everything is normal.
Yes.
Okay.
So to narrow down my further my diagnosis, further I would like to, as an extension of my clinical examination, I would like to proceed.
So you had 3 differential diagnoses.
Yes.
One is a calculus disease, another is a PUJ obstruction, third is a tumor.
Yes.
So considering all these 3 differential, what are the points you look for in your clinical examination?
So clinical examination, any anemia, sir, pulse, increased pulse rate, and any pallor is present, and
Anemia or pallor.
yes, sir.
Anemia, what is the reason for anemia in your mind?
So in case any
General examination.
No hematuria.
No.
Weight loss.
Sorry, sir.
Weight loss, actually one of the diagnoses is renal tumor.
Yes, sir.
Weight loss.
Weight loss. Yes.
Fever.
BP, what is the BP of this patient? It's normal.
Normal, sir.
So, will you look for BP for this patient? Suppose if the patient has got you suspect a renal tumor.
Yes, sir.
Is it important?
Because hypertension being one of the cause for RCC, so I would like to consider the BP also of this.
Hypertension is one of the cause for RCC. It's other way around. Renal tumor, renal cell carcinoma can produce hypertension.
And it also produces hypertension. And moreover, renal tumors and it also produce hypertension.
So, what are the causes of hypertension in renal tumor?
Sir, because of it's a increased renin production from the tumor or any AV malformation.
What do you call it? Suppose if the tumor produces renin, what is the name you?
Reninoma, sir.
Reninoma is a different. It's a paraneoplastic syndrome. One of the manifestation of paraneoplastic syndrome. So one is the tumor can produce renin. Number two, due to
polycythemia also, sir.
No, there are three causes for hypertension in a tumor, renal tumor. One is the tumor can produce renin. Number two, you told it's a AV malformation. Number three,
ureteric obstruction, sir.
Ureteric obstruction. How can you get ureteric obstruction in a renal tumor? So the renal tumor, it can produce obstruction to the renal vessels, mainly encasement of the renal artery. So that can also produce ischemia to the kidney, which again in turn it produces renin. It also all the hypertension is manifested by renin-angiotensin mechanism. These are the three main causes for hypertension in a patient with the renal tumor. Apart from that, you can get a reninoma also. There is a renin producing tumor in the kidney. So the hypertension is not there, but that doesn't mean the patient is not having a tumor. Okay. Number the hypertension. Anything else? Fever, afebrile.
Yes, sir. So fever is one of the another paraneoplastic syndrome associated, sir. So pallor mainly to see.
Oh, you can get fever in a calculus disease also.
Yes,
in a stone.
Yes,
when it is an obstructed infected, in PUG obstruction with the infection also you can get a fever. Okay. What is the reason why they have mentioned icterus? Why?
So icterus in RCC, another new paraneoplastic syndrome is Staples syndrome. It is a non-metastatic hepatic dysfunction. Where, one of the parameter like elevated icterus can be there. Patient will be having.
Cause for the Staples syndrome.
So it is because the increased interleukin 6 production. Sir.
Which cells are affected in this paraneoplastic syndrome, Stafford syndrome?
So thrombocytes and neutrophils.
No, in the liver. Liver has got hepatocytes.
Yes, sir.
And Kupffer cells. So it mainly affects the Kupffer cell function. But usually the enzymes are elevated. Alkaline phosphatase, acid phosphatase, GOTase, DPT. Whereas the icterus, jaundice is not that much common. Okay, you can get due to metastasis in the liver also you can get the hepatocellular and liver dysfunction. What is the cause for pedal edema? Why should you look for pedal edema?
So pedal.
One of you.
IBC thrombus is there, so venous involvement will get pedal edema and abdominal veins also will be engorged. Sir,
Anyone?
Patient can have right side varicocele.
Right side varicocele? Which side you will get usually?
Left side will get.
If it is the tumor arising from the left side involving the left renal vein, should be varicocele. There may be a non-reducing varicocele. Can you get a varicocele on the right side?
We can get, but isolated.
But it's very rare unless the IVC is totally obstructed. But is there any reason, even if the IVC is not obstructed, can you get a right side varicocele? Where does the right testicular vein open?
IVC.
IVC. In all cases? what percentage of cases it opens into the renal vein or at the junction of the renal vein with the IVC. In about 15 to 20% of cases, like even right side also it opens into the renal vein or at the junction. So suppose if there is a thrombus in the renal vein, it can also produce a varicocele on the right side. But it's more common on the left side. Okay.
Stage is the thrombus, level of thrombus.
So, stage 1 is at the ostium, sir, and around 2 centimeter beyond the ostium, and two is below the hepatic vein, sir, and third is beyond the hepatic vein but below the diaphragm. Fourth is above the diaphragm.
Thrombus can occur in IVC, in the case of renal tumors.
Sir, around 10%. 4 to 10%.
4 to 10%.
Yes.
How will you proceed? What investigation are you doing?
So far in your history clinical examination, there is no positive finding which will point to a particular diagnosis. So your diagnosis is still open.
Next, I would like to go ahead with X-ray, KUV, and ultrasound abdominal pelvis.
What is the purpose of X-ray KUV in this case?
So because by differential diagnosis, one of the differential diagnosis is stones also, sir. So
Can you see all stones in X-ray?
if calcification or stone.
Usually the X-ray KUV nowadays it is not done. Not done. Because of when you do a CT scan, you will get a scanogram picture. So that will be enough. So you will do an ultrasound.
Yes.
Read the ultrasound. Read the picture. Ultrasound should be read deluxe. With the existing picture, what do you see?
Which side the pathology is there?
Right side.
First of all, you have to lateralize the lesion. So are you able to see the left kidney at a normal?
Yes, the left side is normal, sir.
As far as this ultrasound is concerned, it looks normal.
Yes, sir.
Okay.
You read the ultrasound.
Right side.
Right side. The pathology is based on right side, as you said. Please read the ultrasonogram.
Sir,
What are things you look in the ultrasonogram in a case of renal tumor?
You had 3 differential diagnoses. One is a tumor, number 2 a stone, 3 is a PG obstruction. So tell me the
I would look for any hyperechoic shadow is there.
which condition you have ruled out by seeing the ultrasound.
Yes.
You cannot rule out by seeing this picture. Carry on. Obstruction, there will be dilatation of the pelvic-calcial system, and you can see the dilated. Are you able to see the dilated pelvis and dilated calyces here? No. So
Renal pathology has been
Ruled out.
PG obstruction. So there are 2 conditions. One is a tumor, another is a stone. Have you ruled out stone?
Not yet.
Got a point.
Picture, you ruled out what else is there?
What else is there?
What do you see space of? Tell me. Read the ultrasound. With the existing picture.
Sir, heteroechoic
Not enough.
No, you are able to see some pathology on the right side kidney. There is no dilatation of the pelvic system, and there is no evidence of a stone. So only is there any lesion on the right side? If there is a lesion, where is the lesion? You tell me.
So on the right kidney, heteroechoic lesion measuring approximately 5 cross 4 centimeters.
Leave about the size and all.
Upper pole of the right kidney, sir.
Upper pole. Can you just show me the lesion? Okay. So what is the? How do you say it is a space occupying lesion?
Sir, it appears heteroechoic, sir. Few areas of hyperechogenicity with predominant hypoechoic lesions, sir.
are able to see the splaying. You can see the fat, sinus fat. It has been splayed. Okay, when you compare with the left kidney, then you can see there is a splaying of the sinus fat, and there is a SOL. Where it is situated? Is it in the cortex, or is it eccentric or centrally located tumor?
Looks like in the cortex.
Cortex. Is it in the cortex?
With the existing picture,
With the existing.
I cannot comment much.
Comment.
Just boldly also example. Yes. With the existing, I like a full ultrasound picture, longitudinal cross section, everything. With the existing picture, I like a better one. It's an example.
Yes. Okay.
Even I can't comment in this.
So, are you happy with the ultrasound? What else will you ask the sonologist to look for?
The vascularity, sir.
Vascularity of the tumor. Doppler study. Doppler for what?
To look for any tumor vessels.
Tumor vessels. What is more important? What is more important? Thrombus. So you will ask the sonologist, do a Doppler study. At the same time, if there is a tumor, to look for a tumor thrombus in the renal vein and in the intra-IVC also. Is it a confirmatory test?
It's not confirmatory.
Which test is confirmatory?
So CECT is the confirmatory.
CECT thrombus? For IVC thrombus, do you think CECT is the confirmatory test?
Sir, at present, CECT and MRI both has got similar.
But MRI will be more useful.
Sir.
MRI will be more useful to identify the tumors. But it's a very good with the high definition ultrasound. High definition, you can very well make out the renal vein thrombus, and in the IVC thrombus, even the extent of the thrombus also, you can make it out. Okay. So there is a space of lesion on the right kidney. Just see
So
the.
what other things you can look in ultrasound? One is IVC thrombus. 95%, nearly 85-95% confirm, we can confirm. There is a mass lesion in the IVC thrombus. What else you can see? What other thing? Lymph nodes.
Lymph nodes, yes.
Liver.
Yes. So any metastasis to the liver. Ascites.
Everything. Yes. With the existing, you be bold with the existing picture. I cannot comment. I like to have more film. Exam will be happy.
So with an ultrasound, you cannot come to a diagnosis because it is a preliminary investigation. Most of the time, it is a bedside investigation, and it is done by not only by radiologists, even the urologist also can do it in the department itself. Okay, then you have to do further investigation to confirm your diagnosis. So, what is the report? You want to know the ultrasound report?
Yes, sir.
So they have mentioned there is a heteroechogenic mass. Suppose if the mass is hyperechoic.
Kidney is normal, right kidney.
Wait. If they say it is a hyperechoic mass.
What is the inference? Can be angiomyolipoma and because it has high fat content in that.
14 into
11 into 10 centimeters. Can you get such a huge angiomyolipoma? Yes, it's possible. So angiomyolipomas will be hyperechoic, and it is in the upper pole. Upper pole. Can you get adrenal tumor? Could it be an adrenal tumor?
Can be severe.
What adrenal tumor you will have? But they say it is confined. It is in the kidney. So only thing is just for a differential diagnosis. Adrenal myelolipoma. That is the most common adrenal tumor. Or there may be a lipoma of the adrenal gland. That also can occupy the upper pole. But here you are seeing a heterogenic mass, 11 into 10 centimeters.
Yes.
Okay. Involving the upper and the interpolar region. To a certain extent, in your ultrasound, you are able to identify the mass in the interpolar region.
Yes.
But the ultrasound didn't give the entire extent of the tumor. Okay.
So what next? Image or better definition of this mass.
So next, I would like to proceed with baseline investigations like CBC, RFT, and urine routine.
All normal.
Yes. Then I would like to proceed with triphasic contrast and CT of abdomen and pelvis. Sir,
Here, just before going for investigations, I mean, imaging studies, laboratory investigations. Specifically for, now you know there is a tumor in the kidney.
Yes.
So what are the lab investigation which will ask specific for this case?
So ESR is elevated, that is one of the paraneoplastic exam.
ESR is mostly non-specific. Will you look for a hemoglobin anemia? You have told anemia.
Yes, sir.
And the RBC count?
Platelet also, sir. Thrombocytopenia.
Liver function test?
Yes, sir.
Serum calcium?
Yeah, hypercalcemia is associated.
Serum calcium?
Yes.
Is that?
Calcium.
Serum calcium is normal. LDH? LDH?
Alkaline phosphatase indeed.
So all the parameters appears to be normal.
Yes.
What is the hemoglobin of this patient?
10.2.
10. Suppose that this patient has got a very high RBC count.
Polycythemia.
You call it as polycythemia. What is poly means all the cells should increase. WBC, RBC, platelet, everything should increase. This is called erythrocytosis. In a renal tumor, one of the manifestation is a paraneoplastic syndrome is increased RBC. It is not polycythemia, we call it as polycythemia vera, or patient can develop thrombosis. Thrombotic patient can develop thrombosis, deep vein thrombosis. So you have to be. Is it important to platelet count?
Mr. In toppers, low platelet count is again one of the associated feature.
Okay. Next liver function test is normal. Serum calcium is also normal.
Yes.
Okay, you want to have imaging study. What imaging study?
Sir,
Can you name what are the imaging studies which you can do for a renal tumor?
So one is triphasic CECT of abdomen.
CECT number 1.
Next, MRI abdomen. Sir.
MRI number 2.
PET CT.
PET CT. You want to do PET CT.
You do all the three.
So-
all the three.
CECT abdomen.
Among these three, which will you prefer?
CECT abdomen.
CECT abdomen.
Otherwise you call this triphasic.
Triphasic.
What is triphasic?
So it's a non-contrast CT along with arterial and venous space and the DDT image.
Non-contrast.
I mean,
It is a contrast CT. Triphasic is a contrast CT.
contrast set like so arterial and corticomedullary or nephrogenic phase and or excretory phase. Yes.
So it is a
Because on an enhancement, when we compare from the plain phase to the venous phase, more than 10 to 15 ounce will enhancement is there, then that we are otherwise. So
this is a plain. Right.
sir, axial plane CT, sir.
Why do you say it is a plain CT?
Sir, because noted and contrast is not seen in the aorta, sir.
So you look for the contrast in the vessels first.
Yes.
Yeah. At the early stage, you will look for the contrast in the aorta. Okay.
How do you read?
Sir,
How do you read it?
left kidney appears normal in size, shape, and position. The PCS looks intact, so left kidney is normal, sir. Sir, axial.
That you have to, you should know from where will you start your CT scan and where will it end? What is the cuts? How many cuts? What is the thickness? It is how many millimeters?
Are you able to tell them?
You have to. You should know about all these things. Okay, we'll because we got short of time. Now you read. Is there any lesion in the kidney? Right kidney is normal or enlarged?
Enlarged, sir.
Enlarged. Right kidney is very much enlarged. Okay. Are you seeing the normal anatomy? You see the left kidney, you are able to see cortex. You are able to see the sinus region, sinus part. Are you able to see the similar appearance on the right side?
No, sir. Right kidney is not.
You read, you have to tell.
So, yes, sir. Large.
So the small between the
occupying the right upper and middle pole. The right kidney is not clearly discernible from the mass, sir. It's not clearly seen. And there is an area of calcification which is noted in the post.
An area or multiple calcifications?
Multiple.
Yeah, you have got multiple
Calcifications.
calcifications are there.
Yes.
In the this calcification was seen in the ultrasound also. You have missed it. An ultrasound also it is seen. Okay.
Heterodense. Yes.
Contrast. You will look ask for the contrast sheet.
Multiple calcifications. What type of calcification is put in RCC?
Dystrophic calcifications.
What is curvature calcification? What is triple calcification? So,
okay.
Contrast film, sir. With the oral contrast, it will be better seen this.
So you will look for the contrast sheet. Show the contrast.
So you have to read renal contrast. Be able to see, appreciate the vein and artery and all those things. Renal, aorta, IVC.
Give some time.
Are you able to see the mass here?
Sorry, sir.
Mass, the renal tumor.
Yes.
Where is the tumor?
Sorry, heterodense lesion predominantly involving the upper pole of the right kidney.
It is a heterodense or heterogeneously enhancing mass. It's not a homogeneous mass.
Heterogeneous, yes.
Heterogeneous mass lesion occupying which portion of the kidney?
Predominantly right upper poles.
Upper pole of the
Right kidney.
right kidney.
Yes.
Then
It,
what is that? What else you are looking for?
So necrotic.
Where is the necrotic area?
Central, sir.
Center necrotic. Does it the center necrotic area? Is it? What will be the appearance? It will be a hypodense usually, but it is not that much hypodense. It may be a soft tissue only. If it then
Enhancement, sir.
enhancement, you have to, it is a heterogeneous enhancement. Occupying the upper and mid interpolar region. Are you able to see the lower pole of the kidney? Normal.
Lower pole I can able to see, sir.
You can't.
You can. I can see.
Another cut section. Okay. You are able to see the lower pole.
Yes, sir.
Okay.
Normal.
Then what about extent of the tumor? Where does the tumor extend?
Extending towards the vein, sir.
Mm.
So
How is the liver? Is the liver is displaced or it is intending on the
It is
lower surface of the liver, and it is extending on laterally? You are able to see the extent up to the abdominal wall. It is lateral abdominal wall. So this such a big tumor is not clinically palpable as far as your clinical, or otherwise if you do a deep palpation, probably this tumor will be palpable. Okay.
I'll ask you a fundamental question. Renal tumor, does it enhance with contrast compared to opposite? What is the normal ounce field in the kidney?
30, sir.
30.
It should enhance more than 15 HU, sir.
After contrast, normal kidney. Normal kidney. You give a normal. What ounce we have a normal kidney?
So 30, yes, sir, 30 to
No,
40.
not 30, it becomes 100. Normal kidney is 45. After contrast, it becomes double, 100. What happens to tumor? So why is the enhancement in CT scan kidney? Where is the contrast present? In a functioning tubules.
Yes, sir.
In tumor, how does it enhance? That's enhance.
See, you are seeing the enhancement on the left kidney, on the right. Does it equal to that of the left kidney?
In tumors, it will less enhance.
Why it is less?
Because
Why it is more on the normal kidney?
tubular.
Yeah.
No functioning
Yes,
kidney.
sir. Destruction will be there tubular. So
See, in our kidney, the contrast in the nephrogram is due to the contrast excreted by the GFR in the tubules. You are seeing it is a tubular phase. You are seeing the contrast. Whereas does the tumor has got any tubules, any glomerulus?
No, sir, no functional tubules in the.
Does not have any glomulus or any tubules. So then why should it enhance with the contrast?
Enhancement which is seen is mainly because of the contrast in the vessels.
It is due to the vascularity. It is due to the vascularity. That's why the enhancement is not equal to that of the normal kidney. At the same time, there will be a early enhancement. The tumor enhances earlier, and there will be a delayed de-enhancement. Okay, when compared to the normal kidney, because de-enhancement in the normal kidney is due to the excretion of the contrast into the collecting system, whereas in a tumor, it is due to the contrast washed out into the venous system. So there will be a delayed enhancement. Early de-enhancement. That's very important. But that is more important in a tumor which is situated in the centrally located small medullary tumors, where you cannot differentiate between a dormitory hump and a tumor. So that in that situation, this enhancement and de-enhancement helps to differentiate between a tumor and a dormitory hump or some nodular phase. Okay, it is given in Pollock. You have to read that also.
So papillary RCC. Type 1 papillaries.
Okay.
Oh, kidney are finished to some extent. It is metro dense mass deficient. And what else you see? IVC, what do you see? Did you look for IVC?
Only say the IVC.
It should be, yes, sir. Actually, it should be collapsed, but here the IVC looks dilated, sir. And but enhancement, I'm not able to appreciate much in IVC.
You enhancement of normally it will be collapsed. No. It is what it is. It is more
dilated, sir.
What indicate why it should be dilated? It's all given follow here. Nothing.
First of all, before going to IVC, you should look for the renal vein. Right renal vein. Are you able to see the right renal vein? You can go into the next pictures. If you're not able to see here properly, you can go to the next series of pictures. Okay.
IVC, how it is distended. What is the distension of IVC show? One is thrombus. One is multiple AV fistula, overflow of blood.
Lymph node compression also, sir.
Lymph node compression, overflow of blood.
Yes.
AV fistula.
But is there any filling defect you are able to see inside the IVC? Suppose if there is a tumor in the IVC, that will also enhance with the contrast. During the contrast, and it is not there. But you are seeing the round IVC, but there is no filling defect in the IVC. So to a certain extent, you can say with this picture that IVC appears to be normal.
Distended.
Distended may be due to increased vascularity.
Vascularity about
kidney
more blood flow goes,
Because of the tumor. Apart from that, what else will you see? Around the tumor, you'll see
lymph node enlargement.
Around the tumor. You are seeing the tumor.
Yes, sir.
Do you think this is a hypervascular or a hypovascular tumor or normal one? Is it a hypervascular tumor? What else will you look for? You have to look for any feeding vessels. You have to look for the neovascularity. Neovascularity, you look for in the periphery of the tumor, where you can see some vessels. Are you able to see any neovascularity here? Not much of neovascularity. Suppose there are a lot of neovascularity, then it is a hypervascular tumor. So it doesn't look like a hypervascular tumor. Okay. Next, and the IVC appears to be normal. Nodes. Where will you look for the nodes?
IVC you can't see normal.
Yes,
you have to keep in mind.
Yes.
The IVC is normally collapsed.
Yes.
It's a flat. IVC pressure is 0 to something. So it is distended.
Where will you look for the nodes?
So hilar and intrahilar.
Renal hilar.
Yes.
Hilar nodes. Number 1. Number 2.
Intrahilar.
What is the lymphatic drainage of the right kidney?
Right precable, paracable, interaortic cables.
Interaortic cable. Why do you look for interaortic cable? It is it's a paracable, retrocable, because the vein lymphatic system follows what?
Trilaminar plexus.
The vein or artery?
Veins.
Vein. So the right renal vein joins the IVC here. So you will get a paracable and a retrocable. Interaortic cable usually occurs in the left side tumors. So paracaval nodes you look for. Are there any nodes here? Obvious nodes are there?
No, sir.
No.
What is the prognostic significance?
So lymph node involvement doesn't have any prognostic significance in RCC. Just for the staging purpose, it's done.
Staging is also a prognostic factor.
Staging, it has got a lymph node involvement has got a poor prognosis when compared to the hematogenous. Number two, the lymph node enlargement may not be due to the metastasis. It could be due to what? What else can produce a lymph nodal enlargement in a renal tumor? Reactive hyperplasia. Have you heard about this term? It's given in the book. Huh? No, it's in Campbell also it is given. It could be due to reactive hyperplasia. So all lymph nodal enlargement need not be malignant. But if the tumor, if there is an enhancement of the lymph nodes, then similar to that of the tumor, then it could be malignant. Okay. Are there any nodes here?
No, sir.
No. Liver?
Liver looks compressed, sir.
With this pictures, liver appears to be normal. Is there any mets in the liver?
No, sir.
No. Okay. Then what else? What else will you do?
CT scan, what is the stage?
What is the stage?
What do you want to further investigation?
Now, what is your diagnosis?
Sir, with this, it will be.
What are these calcification? There is one calcification medially, just adjacent to the IVC. Is it a stone?
RCC.
And where will you get calcification?
Curvilinear calcification.
In RCC, you will get a curvilinear calcification.
Periphery or in the center?
You told me, is it a metastatic or it is a dystrophic calcification? There are two types of calcification, metastatic and dystrophic.
Yes.
Is it a metastatic or a dystrophic calcification? It is a dystrophic calcification because of the necrosis. Necrotic tissue will get calcified. So it will be that within the tumor. It will not be curvilinear calcification. Which condition you will get a curvilinear calcification? If you tell like that, then the examiner will ask you, when will you get a curvilinear calcification?
Simple recalcification, curvilinear calcification.
You can get in a simple renal cyst. That also can, or most common, apart from simple renal cyst, is hydatid cyst. You will get a curvilinear calcification. Hydatid cyst is not common here. Okay. Yeah. So you will get a multiple spickled calcifications in the center of the tumor. This looks like a stone. Okay. Now, what is the stage? So CT, you have to stage the disease, tumor.
Yes.
Size. CT report do you have? Okay, it's 11 centimeters tumor.
So that comes under but T2B, sir, but because the IVC also looks dilated, so it can be T3B.
No, that is not confirmed. You have not confirmed it.
So it is T2B 0 M0. So T2B N0 M0. Mean like
what is T3?
So T3 is again.
Now tell me the staging. What is T1?
So T1 is less than 7 centimeter tumor. T1A is less than 4 centimeter. T1B is 4 to 7 centimeter.
4 to 7.
T2 is more than 7 centimeter. T2A is 7 centimeter and T2B is more than 10 centimeter.
This is 11.
11, sir. So T2B.
T2B.
And
what is the location of the tumor? Is it also important?
Within the Jericho space, yes.
Within the Jericho
space, yes.
This tumor is centrally located. It is in the upper pole, extending into the interthrombal region where there is a renal sinus tract.
Yes, sir.
Suppose if there is the tumor is located there, what is the stage?
T3A, sir.
T3A. So this tumor may be, this is T3A. Okay. IVC and the renal vein thrombus is not there. Nodal status?
N0, sir.
N0.
So metastasis, I would like to do chest X-ray or if patient is symptomatic.
CT chest.
CT chest.
Don't say chest X-ray, CT chest. Nowadays only CT chest.
Spine examination?
Sorry, sir.
Spine. We do the spine examination.
Will you do a bone scan in this patient?
No, sir.
No. unless the patient has got a
Symptomatic.
symptoms, unless the patient is symptomatic, there is no need. Raised or
Raised or is.
CT chest, you want CT chest, X-ray chest, CT chest. And in the CT chest, the examiner will ask what will you look for, where are the mets, what is the shape of the mets?
Cannonball
Cannonball.
Cannonball secondary.
Why only one, you answered me. Why it is called cannonball mets? That is the only question. Well, you can say it is a cricket ball or golf ball, no? Cricket ball, football.
What is cannon?
Why do you say it is a cannonball mets?
What is a cannon?
Have you seen cannonball? If you go to the museum in Egmore, they have displayed the cannonball. Will the cannonballs are each same size or for different sizes? Shape will be round, but size is varies. Depends upon the lumen size of the cannon. So similarly, the mets also, it will not be of same size. So it will be, one will be smaller, one will be medium size, one will be bigger. So that is the reason why it is called a cannonball. Otherwise, they would have called it as a cricket ball. If it is a equal size, then they will call it as a cricket ball. So it is the particular reason for it is why it is called cannonball. It is of varying sizes. Okay?
Yes.
In the parenchyma. That is the reason. Are you able to see any mets in the X-ray test CT?
CT.
Sometimes the CT scan may be misleading because our country, the patient might have had a tuberculous lesion. He may be having a healed tuberculous lesion which can produce some fibrosis, mediastinal nodes are there sometimes. But CT will be more useful.
Looks normal.
Normal, okay. So what is your plan?
You spine secondaries at present. What type of secondaries you expect in?
Osteolytic metastasis.
It's not osteolytic. It is osteolytic.
Lytic, yes.
Now you stage here. Finish the case.
Yeah.
Stage the disease.
So T3A, sir, N0, M0.
N0, M0.
Ruled out IVC thrombus.
Yes, sir.
You like to have MRI.
Or at least you should have asked the sonologist to do a Doppler.
IVC is distant. You have MRI.
Doppler then. What is the Doppler? Please?
No, sir, no evidence of
So that is N0, M0, T3A.
Yes.
Yes, normal.
So what is your plan now?
Sir, first I would like to stabilize the patient because hemoglobin is 10.2. So
10.2 is okay. Would you like to still give blood transfusion for this patient?
or reserve 2 pinch per hour.
Reserve blood, okay.
Yes.
Next. Now, what is your plan in this case? Are you going to leave the patient alone? Are you going to give do surgery, radiotherapy, chemotherapy? What is your plan?
So surgery is an open radical nephrectomy with lymphadenectomy.
Lymphadenectomy, is it mentioned like that in the book?
Not quite, but
blood dissection.
What do you mean by radical nephrectomy? Is it
But you will one question. Will you do open or a lap?
Open better for this case because more than 10 centimeter tumor. So
people are doing more than 11 centimeters. They are doing open. I mean lap radical, lap radical. You can say, but here you are doing both lap and open. Okay. But if you say it is open, the examiner will not find fault with you. He will ask you, why not a lap radical nephrectomy? Okay, then you must know the steps of lap radical nephrectomy and also open radical nephrectomy. Okay. So, what are the structures you remove in a radical nephrectomy?
So that
then why do you say it is a lymphadenectomy? Will you remove do a block dissection here?
No, sir, not routinely done, sir.
So what are surgeries you do in radical?
So kidney, including the geratosphagia, and adrenal is removed only when there is tumor with the kidney and including the geratosphagia, and adrenal is removed only when there is radiological.
No, in this patient.
Upper port, so adrenal will be removed.
Adrenal gland. Why do you want to remove the adrenal gland?
Yes, sir.
Does it attach to the tumor or it will be a separate compartment?
Because gerotos covering will be including the adrenal surgery.
No, there is a There is a small layer of gelatinous fascia which separates the adrenal gland. Why? But you want to remove the adrenal gland because adrenal mets are more common.
Upper pole tumor.
Upper pole tumor. Okay, you remove the adrenal gland, so but you should know the steps of our open radical nephrectomy: incision, positioning, incision. Suppose if there is a tumor thrombus, what will be the incision? If there is no tumor thrombus, what will be the incision? What incision you routinely doing here?
Extended subcostal, sir. Like from the lateral border of the rectum.
Lateral incision, loin incision through the bed of the 11th rib.
Yes, sir.
What are the other incisions?
Chevrons, sir.
You got subcostal. It's not chevron, it's subcostal. Midline incision also you can do.
Transabdominal, transperitoneal midline incision.
Okay.
Suppose one of you find notes, will you not go for it?
Will you do a block dissection? Is the term block dissection is there?
No, sir. Block dissection
is not there.
Not there.
But you will remove all the nodes which are all enlarged. Which are all seen. Yes, it is included in the radical.
Yes.
Okay.
You have to know notes.
So what will you do? What will you do the specimen? So you have completed your radical nephrectomy.
Yes,
and what will you do after that?
So we have to know the histology of the tumor, sir. Whether it is a clear cell or a papillary or a chromophobe, like the primary histology of the lesion.
So what do you expect in this patient?
So most probably if a clear cell.
What is the most common tumor?
Clear cell arthritis.
Clear cell carcinoma.
Can you judge a tumor histopathology by all this?
Most common is clear cell carcinoma.
Okay, clear.
So what are the other types?
You cannot guess.
Yes.
What are the other types?
So papillary,
Papillary RCC,
chromophobe, collecting duct, medullary.
Anything else?
Undifferentiated. Right.
Anything else? Can it be a sarcoma? Apart from the renal cell carcinomas, you can get a sarcoma. Usually the sarcomas are very big. Calcifications are more common. Can it be a Wilms tumor?
Yes, sir.
Because of calcification, adult Wilms tumor can get it. Okay? Still it is possible. So how will you follow this? So you will send the specimen. Okay? You want the histology.
Clear cell pathologist.
Clear cell carcinoma. Happy?
That's all you want.
You are
Happy with
happy?
histology?
You want to know the first is histological type. Number 2 is grade. What will be the grade? How do you classify?
Any associated necrosis?
Grading. Which grading system you follow?
Names.
12 months grading system. Grading. Number 3.
Say conjoined capsule.
Necrosis. What is more important? Lymphovascular invasion.